So without further ado, I will hand straight over to Sean and to Liz to get us officially started. Thank you both.
Thank you, Russell. Very good morning, afternoon, evening, everyone, and welcome to the Global Mesothelioma Education Forum. My name is Sean DeLu. I'm a consultant medical oncologist, and I'm based at Leicester, United Kingdom. I have the honor to chair today's event along with very eminent people in this field of mesothelioma with Liz Dawson, Professor Dean Fennell, and Professor Kevin Blythe. So this is our initial event, and we'll bring this together by Thoracic Oncology Frontiers in collaboration with the International Mesothelioma Interest Group, UK3CR, Mesothelioma UK, and the Predict Meso Group. Wherever you are joining us from today, whether you're just starting your day or winding down towards evening, thank you for being here. The fact that we can actually bring people together from so many different time zones and all with a shared purpose, I think says a great deal about the strength of this mesothelioma community and how much this disease continues to demand our attention and our collaboration. I would like to begin by acknowledging who's actually in this room with us today. We have virtually everyone, but much together. And we have patients, carers, healthcare professionals, various charity organizations, solicitors, all who play a role in improving outcomes for the people affected by this disease. So this forum has been set out for all of you. We are aware that mesothelioma remains a rare and challenging cancer. Across the world, researchers and clinicians have been pushing the boundaries for what we know for a period of time, understanding the fundamental biology of how this disease develops and progresses, to the latest advances in precision medicine, the evolving role of radiotherapy, the continuous discussion about surgery, and the particular complexities of peritoneal mesothelioma, which is so often under-attended. So today we have the privilege to bring together an outstanding group of speakers joining us from Australia, Hong Kong, France, the United Kingdom, and the United States of America. Each of them will bring a different perspective shaped by different healthcare systems, different research environments, and different patient populations. But their common goal is united to improve the lives of people affected by mesothelioma wherever they are in the world. So over the course of this forum, you'll be hearing talks that span the full breadth of the disease, from understanding the biology to the cutting edge of precision medicine and targeted therapies, to various advances in radiotherapy techniques and surgery as well. Our aim is not to simply present information, but to translate science into understanding and to make sure everyone, when they leave this forum, feels more informed and empowered, and that healthcare professionals leave with fresh insights they can bring back to their own clinics and their own patients. So on behalf of everyone who has helped to bring this event together, thank you for joining us today. Thank you to our speakers for generously sharing their time and expertise. And thank you most of all to the patients and carers in our audience. This forum is ultimately for you. Without any further delay, I'm going to hand over to the chairs of the first session. That will be Liz Dawson and Kevin Blythe. Liz is a consultant nurse and has been a nurse who has enjoyed more than 40 years of clinical practice at the University Hospitals of Leicester. And she has done remarkable work in the mesothelioma area, and she's also the CEO of Mesothelioma UK. She has honorary university positions in both Leicester and Sheffield, and has been passionate about improving experience and outcomes through clinically based research, keenly promoting the NHS and nursing as a career, and engages very well in education and training at many levels. In 2019, at Queen Elizabeth's birthday honor list, Liz was invited to become a member of the British Empire in recognition of her services to patients and cancer research. And in May 2024, she was appointed as a Deputy Lieutenant for Leicestershire. Kevin Blythe is my other chair, and he's a Professor of Respiratory Medicine in the School of Cancer Sciences at the University of Glasgow. And he spends his time between research and clinical practice, and he's been leading on the mesothelioma work done in Scotland. He's a national clinical lead for the same. He leads the Predict Meso International Accelerator Network that's been funded by Cancer Research UK. He's also the academic lead for the UKRI-funded Living Lab Radiogenomic Project, which has developed a pipeline of deep phenotyping for unconsented archival tissues, radiology, and clinical data. So over to you, Liz and Kevin.
Thank you, Sean. Thank you for that lovely introduction.
Sure.
Kevin and I have decided that I'm going to introduce the speakers for this session, and then Kevin's going to wrap up the questions at the end of each speaker. And I just wanted to say to those people on the call, if there are questions that come up that you want to ask that are particularly about you, then please think about reaching out to your your own support networks with questions about you particularly. Mesothelioma UK is really keen to be there for you, and you're going to learn more about some other international organisations later on. So do pick up the phone to people. And I also wanted to say I'm wearing my Action Meso Day t-shirt. It's Action Meso Day in the UK tomorrow, and I'm just absolutely delighted that Thoracic Oncology Frontiers, Sean and the team said they wanted to do something to mark AMD, and we thought that we've got an international community, let's shine a light on that, because working together we can hopefully do more to combat this disease. So without further ado, I'm going to introduce our first speaker, and it's very fitting that our first speaker is Professor Anna Nowak. Anna is the Deputy Vice-Chancellor at the University of Western Australia. And in the interest of time, I'm not going to read your whole bio, Anna. Suffice to say that you have got the most respected and amazing career academically and clinically in mesothelioma. And currently, you are the president of the International Mesothelioma Interest Group. And Anna's going to talk to us about the key challenges from an international perspective. Over to you, Anna.
Thank you so much, Liz. And while I share my screen, I'm just going to also take the time to thank everyone who was involved in organising this. It's just a fantastic opportunity to get the mesothelioma community together, and really proves that you can actually join people across a number of continents. So I am speaking out of my area of expertise today. I am a medical oncologist, and I've been asked to speak on the key challenges from an international perspective, and clearly that is because of my role as president of the International Mesothelioma Interest Group. And one of the things that's very important to me in this period as president of IMEG is to actually expand the membership into other parts of the world that are currently poorly represented, but which you'll see through my talk really should actually be a part of our mesothelioma community, because they are likely to be, even if not demonstrated by the data available, experiencing mesothelioma epidemic as well. So I'm going to give a shameless plug for IMEG and ask people to whip out their phones and scan the QR code and join IMEG today. It costs nothing. At the moment, you will get a quarterly newsletter and certainly be connected around activities such as conferences. And we're still expanding what we can do within the resources available to IMEG. So having done that shameless plug, I will move on to the rest of the talk. Now, what is our global problem? We're always a little behind in the data, the global data, due to the time required to harvest the information, but we are currently looking at over 30,000 new cases of mesothelioma worldwide, over 25,000 deaths from mesothelioma worldwide. And when we consider the impact of asbestos, asbestos-related deaths, that is more than 90,000. And still, the 5-year survival is less than 10%. And although we have many new and exciting treatments, 5-year survival remains low because not everybody has access to our new treatments and not everybody will respond to our new treatments. So that is a difficult truth, but it exposes the scale of the problem, particularly when we consider that mesothelioma may be almost entirely preventable. And so some of this talk is going to also make those links between what we know about mesothelioma incidence and what we might be doing about it in terms of asbestos exposure. And I say here what we know because actually we don't necessarily have any way of matching this incidence up with the truth and what the actual incidence is around the world. We see these hotspots: Australia, South Africa, North America, Western Europe, Russia. But we also know that mesothelioma incidence is likely to be very much underrepresented in some other areas of the world, such as India and China, where asbestos use remains. And I'll go into why that might be in a moment. Drilling down a little bit into more detail on the incidence, again, you see this, this gap where we know that asbestos is being used, at times is being mined, and yet we see a low recorded incidence through our global systems. Now, when we think about global disparities in mesothelioma, we must think about what is the global regulation landscape. Thankfully, more than 60 countries have banned all forms of asbestos, and that it does include most high-income nations. There were early adopters such as Iceland. I am embarrassed to say that in Australia, we did not fully ban asbestos until 2003, despite being well aware of the mesothelioma epidemic and the risks of asbestos exposure. But there are still some really notable and important gaps, particularly major asbestos producers and users that haven't fully banned asbestos. Russia, China, and India continue to produce and consume significant volumes, and the USA has only partial restrictions. With a global ongoing consumption of around 1.3 million metric tonnes per year, Russia is leading global production, with Kazakhstan and China hot on the heels. Yet we see that the incidence of mesothelioma, as reported in the previous map, represent a match with the amount of asbestos production that we know is going on. And high demand persists in parts of Asia. Asbestos is a wonderful insulator. It's a wonderful fire retardant. And so building materials like roofing sheets, particularly in areas where poverty is endemic, this is where asbestos is used. And Laurie Kazan-Allen from the IBAS Secretariat has really made it her life's mission to be monitoring and following the global regulation landscape. So if you do want to know more, I refer you to the asbestos ban list that you see here. So what is the impact of the regulatory disparities that those of us on the webinar today need to think about? We know that countries with bans have seen a plateau or even decline in the rates of mesothelioma, and countries with ongoing use face rising incidence, but not all of them are looking, not all governments are appreciating and understanding this. And there are concerns that some areas are making a clear policy decision to not look so as to not need to disrupt the industrial mining or the use of asbestos. So the lack of that global asbestos ban and unified regulation really creates challenges with cross-border trade. This doesn't simply impact those countries where there is no asbestos ban. It can also impact countries where there is an asbestos ban, but small amounts of asbestos do enter in items as disparate as building materials and, shockingly, as children's toys. So for the clinicians on the call, we need to recognise the global variability. We live in multicultural societies where people may present in our clinic in a country with an asbestos ban, but they may come from a country of origin or with a work history that needs to be evaluated clinically so that we can consider, is mesothelioma, is an asbestos-related disease, something that they could be at risk for. For policy leaders, the call which has been heard very clearly in many parts of the world to internationally harmonise regulations and to support a global asbestos ban, is one that we should continue to be advocating for, including to ensure that chrysotile is banned around the world as well. So we have disparities in the use of asbestos, our key risk factor for mesothelioma development, but we also have disparities with challenges in diagnosis around the world. Areas such as that I work in, Australia, there's a very high awareness of the possibility of mesothelioma for pleural disease, and there's also very good diagnostic expertise. But in areas with a lower mesothelioma incidence, we need to be aware that clinicians may not think of mesothelioma, that the specialised testing and experienced pathologists may not be available, and that there may be access barriers to best practice imaging that results in misdiagnosis or underdiagnosis, contributing to the global disparities in reporting of mesothelioma. So leading to missed and unreported cases. We'll also see the advent of lung cancer screening in many countries, and that may increase early detection through the identification of asymptomatic pleural disease, small pleural effusions that are then investigated. So my call to policy leaders is to strengthen diagnostic capacity worldwide and to improve training for clinicians in recognising asbestos-related diseases, as well as to support establishing mesothelioma registries. So we have the asbestos exposure disparities, we have the diagnostic disparities, but we also have very, very wide treatment variability worldwide and variable access to state-of-the-art medication and care. Access to treatment very much varies by region, and many of us on the call will come from high-income countries in which dual immunotherapy specialist centres, multidisciplinary teams are available. But I do want to highlight that even in high-income countries, dual immunotherapy is not uniformly available. I still believe that New Zealand has no funding on their public health system for access to dual immunotherapy for mesothelioma, and that in itself creates an access barrier to people for financial reasons. And in many countries, rural and remote access disparities are very real, and certainly can see that in Australia. So we do need systems that can mitigate the financial barriers for patients and reduce the economic burden that is one of the creators of health disparities in mesothelioma care. We have the occupational differences around the world, and the sources of exposure vary very much by region. Where I am, this was mostly exposure due to asbestos mining, milling, and subsequent use, often in building materials. In the UK, we know that shipyard workers are at high risk. In India, we know that those that dispose of, for want of a better word, the carcasses of dismantling ships are at high risk, and mechanics working with brakes in other countries. But we also have the decades of asbestos cement manufacturing in Casale Monteferrato in Italy, leading to elevated rates in nearby residents, and in other areas where naturally occurring minerals such as erionite cause high mesothelioma incidence, reflecting the environmental exposure in areas. So along with my ever-expanding list of calls for policy modification is the need to ensure that occupational safety and environmental controls are important policy instruments around the world for preventing further exposure to asbestos and further development of mesothelioma. And this is, of course, patchy, as is the enforcement of workplace protection for remediation of asbestos contamination and remediation of sites as well as houses and building materials. Many countries are not fortunate enough to have surveillance systems such as mesothelioma registries. And this gets back to my early slides around the invisible cases of mesothelioma that we suspect, strongly suspect, are there, but have difficulty identifying for global awareness. And this, of course, impedes effective global policy response as well as effective local policy response. There are very wide variables in the compensation systems for occupational disease, some being state-run and others being through a very adversarial legal system or very costly adversarial legal system, such as in the US. But this is not, of course, at all uniform, and there are many areas where people have no formal support or compensation from their occupational exposure to asbestos and development of mesothelioma. So I think my 15 minutes is up, barring a couple of minutes for questions. But that was a very quick tour across some of the challenges that we face globally in our management of mesothelioma and the different perspectives around the world at the level of asbestos exposure, asbestos policy, occupational exposure, treatment disparities, diagnostic disparities, and clinician awareness. So we really need to have that coordinated international action. Bans are not simply enough. We need to also look at what can we do to ensure government enforcement of bans locally. We need to resolve the data deficits for that true global picture that will then springboard into international action. And we do, of course, need effective treatments, but those effective treatments should not only be available to those in high-income countries that can afford them, but the potential for global affordability for all people with mesothelioma I think that's also really important. And until we have global affordability, we will continue to see 5-year survival of under 10% when we're looking at the big international picture. And of course, global research collaboration is also critically important. And that, of course, is one of the roles that IMEC has an emerging place in. So thank you for your attention. And these are my contact details, and very grateful for the support of the IMEC community in enabling me to be president of this wonderful group of people dedicated to eliminating mesothelioma and improving lives of people with mesothelioma.
Thanks very much, Anna. I don't know if you can hear me. Yeah. Anna, we've got time maybe just for one question, if that's okay. I mean, there's a very good question from Orlean Brito that's been put in the Q&A, which actually I think you might have actually addressed as you went through your talk, which is around whether there were global models that actually integrate prior occupational exposure with current environmental hotspots to try and prevent these increasing numbers of non-occupational environmental exposures. And I think you'd suggested that we don't really have those in many countries. I mean, to try and fill that gap that you've described, I wonder if you could comment on the role of that maybe us as clinicians and researchers could have in terms of maybe cohort studies that we could build to kind of try and collect some of that information. And maybe we've got lots of patients, I think, on the webinar as well. You know, what can citizens do in the various countries around the world in terms of maybe applying pressure to their local members of parliament or other things to try and lobby for registries to be created?
Yeah, I know that there are many people on the call here, and I'll give a shout out to Linda Reinstein, who really know a lot more about this than I do, and have made it their life's work to campaign against asbestos exposure. I think one of the challenges is where does the political will come from? And there are democracies in which citizens are able to lobby and vocalise against a problem, and there are democratic mechanisms for government listening to them, and for change coming about as a result of people's voices. I know that in some of the areas where there is underreporting, yet asbestos use is high and asbestos mining is high, there may be a different government perspective when people attempt to lobby or agitate about asbestos exposure, asbestos reporting, and asbestos mining. I think it's probably best if I don't say any more in a recorded public forum, but yes, for those people in countries where they have asbestos disease organisations, where they have political democracies, and where they have avenues to reach their political representatives, please do so.
Thank you, Anna, and thank you very much for a great talk. I'm going to pass the baton back to Liz to introduce the next speaker, if that's okay, Liz.
Yeah, lovely. Thank you, Kevin. And thank you, Anna. And I echo what you said about getting involved with your local group and doing what you can to have your story heard and raise your voice. Our next speaker is Professor Martin Wong, who I understand is based in Hong Kong. He is a family medicine and international scholar in the field of cancer screening and prevention of chronic disease. Unfortunately, Martin couldn't be with us live today due to timing and so on, but we have a recording of his presentation, and it's about the global burden of mesothelioma. So Russell, if you'd like to play the video, please.
Hello, good day, everybody. This is Professor Martin Wong, a professor from the School of Public Health and Primary Care of the Chinese University of Hong Kong. I wish to thank our organizer for offering me this opportunity to present the global burden of mesothelioma by giving a current update. So these are my disclosures. I don't have any actual conflict of interest on this topic. So as a start, mesothelioma is a cancer that begins as a growth of cells in the mesothelium. So what is mesothelium? This is in fact a layer of tissues that cover the lungs. Now we can see here, these are the layers covering the lungs. These are the layers covering the heart. And these are the layers covering the testes. So for mesothelioma occurring in lungs, it accounts for 70 to 79%. For abdominal wall, it accounts for 10 to 30%, the heart 1%, and testes is less than 1%. So when we talk about this disease, we are referring to mostly plural mesothelioma. That means the majority covering the lungs, but the others should not be neglected in our discussion. So we might really wonder who are having risk factors for developing mesothelioma. And I think the number one risk factor we can think of is exposure to asbestos, which is an industrial mineral fiber. And there are at least 6 varieties of asbestos with different color and also risks. So we can see in this diagram, these are the 6 types. Of course, we have to mention zoonites, cigarette smoking, exposure to radiation therapy, age being older, meant, and genetic causes such as mutation of genes and infection of a virus called SV40, which usually infects the monkeys. So the high-risk groups also consist of people who got the mutation of genes called BAP1, and also those having family cancer history. So these follows very closely patterns of melanoma, kidney cancer, breast cancer, and mesothelioma, etc. And of course, we have talked about asbestos exposure, and also, in fact, secondary exposure, such as family members exposed through contaminated clothing or household dust, may be more allergic if they carry a genetic mutation. So this shows the 6 types of asbestos with their risks, ranging from high, moderate, or very high and extremely high. And I think these are actually for references of our audience. So how can asbestos cause mesothelioma to develop? And of course, the first thing is that we inhale asbestos fibers in industrial settings into our lungs. And secondly, asbestos fibers will launch in the lungs and also the abdomen. So we can see here, when they're launched there, the asbestos fibers then will mutate the cells. That means they will change the genetic materials in the cells over time and become malignant. That means it becomes cancerous. And a mesothelioma tumor develops usually after 30 to 50 years. And this is the global burden of diseases. As we can see here, on the left-hand side, we've got male and female. And we can see the darker is the color, the more likely is the person having mesothelioma. So, and also on the right-hand side, we've got the young and the older. So we define them as 15 to 49 years old and 50 to 74 years old. The highest age standardized weight was found in Northern Europe, Australia, and New Zealand, as we can see here, and also Western Europe, Southern Europe, and Southern Africa. In contrast, the lowest age standardized weight was found in Caribbean, Eastern Africa, Western Africa, Middle Africa, and South Central Asia. A 23-fold difference was found between locations. And for countries, the highest incidence rates was found in Luxembourg, United Kingdom, Australia, and the Netherlands, New Zealand, and Belgium. And the lowest incidence rate was found in Bangladesh, Sudan, Nepal, Panama, Chad, and Pakistan. So how about in the male population? I think the global incidence of mesothelioma as measured by the age standardized weight was only 0.46 per 100,000 persons. So it is 21,560 cases. And the female incidence was much lower, as you can see in the diagram, than the male counterpart, with an age standardized weight of 0.17. That means only 9,310 people. And the highest incidence in males were found in, again, Northern Europe, Australia, and New Zealand, and Western Europe. And in females, it was in Luxembourg, the United Kingdom, and the Netherlands. So these diagrams show that it's very important for us to identify countries or regions with the highest global burden of mesothelioma. So we might probably really wonder who are the high risk groups in terms of occupation. Now, of course, those manufacturers which produces asbestos, and the laggers and the insulation workers, as well as shipbuilders and dock workers. Well, in addition, the carpenters, plumbers, electricians, the welders and steel erectors, and the power plant workers are at high risk of having mesothelioma. Now, don't overlook that particular disease. In fact, this could be very, very disabling. For example, it can cause fever, night sweats, and also fatigue. And this could be disabling enough, causing the patient being unable to go to work or carry out their activities of daily living. Sometimes people may experience unintended weight loss, as well as symptoms of the digestive system, like diarrhea, constipation, abdominal pain. Sometimes they have shortness of breath, cough, and difficulty swallowing because of the accumulation of the asbestos or the other pollutants in the respiratory tract or the gastrointestinal tract, and also because of the tumor itself. And the blood pressure and heart rhythms may be affected. They may encounter chest and abdominal discomfort, and also swelling, lumps, or pain in the scrotum for testis mesothelioma. So for the global burden is in fact a rare disease. It accounts for only 0.17% of the total estimated cancer cases. So these are the number of cases seen here. But then, however, they are very important because their 5-year relative survival rate was as low as 12% as of the year 2020. And for all cancer, the 5-year survival rate was up to 62.7%. And the difficulty is really about its very, very long latency period. So from exposure to asbestos to the occurrence of disease, it requires around 30 to 40 years. So therefore, one which absorbs asbestos or having high risk exposure to industrial waste may probably not attend medical doctors because they have no symptoms. They need to wait for 30 to 40 years. By the time when they develop mesothelioma, is probably sometimes too late. The age standardized rate was 0.3 per 100,000 persons. Now, these graphs are really just showing that as the Health Development Index, an index showing how developed a country or city is, if it's increasing, then the incidence of mesothelioma increase as well. So as the gross domestic product per capita, and of course on the horizontal axis is occupation exposure to asbestos. It's really just to remind us that in richer countries and for people with greater exposure to asbestos, the global incidence of mesothelioma increase. So this is the trend analysis. So for male on the left side and for females on the right side, we also developed the upper and the lower panels according to the Human Development Index. So the upper panel one, the countries got higher income, and also lower panel one, generally speaking, the country is less developed. So we can see here, this is a disease which should not be ignored because in a number of the countries in Europe, also in Southeast Asia, they're increasing. So the bars are on the right-hand side. Similarly, in females, there are around half of the countries study also pointing towards the right. That means they're increasing as time goes on. So for lower income countries, so we can see there are also some countries having increasing mesothelioma, and so are countries with low Human Development Index. So what are the impacts of mesothelioma? Of course, we talk about the various symptoms, which may be very, very unpleasant and affect our activity of daily living. Now, another very important impact is on patients. So the patients may experience very severe anxiety and also psychological symptoms like depression, post-traumatic stress, and also they have concerns regarding their existence due to the terminal nature of the disease. So it's actually a very severe disease. And also we've got gender-specific issues. For example, patients with peritoneal forms, that means the mesothelioma affects the abdomen. They may have poor body image because of the severe abdominal scarring or swelling alongside a loss of fertility, because mesothelioma could also affect the testes. Now, it really only just affect the patients, but also the caregivers, because the caregivers may experience very high rates of depression, isolation, hopelessness, and intense financial strain because of the efforts and also resources required to take care of the patients. And then they would expect only 18 months in terms of average life expectancy. And we are very, very concerned about its global footprint, which kills 2,500 to 3,000 people. And these are the most common mesothelioma symptoms by type. So for the lungs one, we got shortness of breath, chest pain or tightness, dry cough, unexplained weight loss, etc. So for the different types of mesothelioma, they present with different repertoire of symptoms. So apart from the patients themselves, we would expect the impact of mesothelioma will also lie on our society. For instance, it could reduce productivity. Now imagine if a person is 50 years old and is already a leader. The leader having mesothelioma will no longer be able to lead the whole team. So therefore, there is a very serious question of whether the leadership of a company or the whole society may be affected. And also, we would expect job absenteeism and turnover because of treatment required, attendance to medical clinics and consultations. So we have a question: will our future leaders sicker if they have the mesothelioma at their 50s, who are their prime time in terms of their career? Now, of course, its impact is also on public health system. So the burden is on health service utilization. So because if there are more and more people with mesothelioma, they visit their medical doctors more frequently, there will be a higher healthcare expenditure associated with it. And also, one would expect side effects of medications used to treat mesothelioma. And also, for mesothelioma, as the scientific research is advancing, we would expect advanced technological equipments and expertise sometimes required. So I think for mesothelioma, it doesn't really just affect a person's health in terms of physical, psychological, social, and spiritual health. Okay, its impact is beyond the patients. It would affect the caregivers, the family, the society, and bigger one, such as the public health system. So therefore, ladies and gentlemen, we need to have a bigger concern and also discuss on ways to eradicate the disease. So with this, I wish all of you healthy and also enjoy the rest of today's function. Thank you very much for listening. Many, many thanks.
That was fabulous. I'm going to jump in because our next speaker is is the chair of this session, Kevin Blythe. Unfortunately, we can't take questions for Martin, but if you want to pose any questions in the chat, we'd be glad to forward them on. And now from Hong Kong, we're going to Scotland and to Kevin Blythe, who's going to talk to us about understanding pleural mesothelioma. And we're a bit behind, Kevin, so I'm going to challenge you to try and catch us up a bit.
Okay. I'm not famous for that, but okay, I'll do my best. Thank you very much to Sean and Liz and Dean for the invitation to participate in this and on behalf of Predict Meso, and just personally, it's a real pleasure to be involved. So I've been given this rather broad title, which I did need a wee bit of guidance on exactly what the guys wanted me to cover. But what we're going to try and cover in the next 15 minutes or so is really just to try and set the scene for some of the later talks. I'm going to just touch on some themes really in terms of what we know, and I'm going to spend most of the talk talking about gaps in our knowledge and try and suggest strategies that will help us develop better therapies and achieve what we all want, and that is better outcomes for our patients. So in terms of what we know, Anna's covered really the very clear and consistent link between asbestos exposure and mesothelioma in the vast majority of cases. And I think it's fair to say that outcomes remain poor and certainly are not where we want them. I think when we start to think about why that might be, it's useful just to look back at our track record, if you like, how of all the trials that we've done, how many of those have been successful and that they've led to a licensed therapy. And you can see there that graph shows really a quarter of a century of human mesothelioma trials, phase 1 to phase 3. There are 375 trials there. And unfortunately, in the UK, certainly this will vary a little bit, but in the UK, we have only 3 licensed therapies that you can see emerging from those 3 trials. That is inferior to all of oncology. If you take, there's a kind of large meta-analysis there published by Wong and Sia 6 years ago now, which reported over 400,000 trials. And mesothelioma, it have been harder to achieve licensed therapies in meso than it has been in other cancers. And more recently, the success rate is now above 10% with the emergence of immunotherapies and targeted therapies. So we do need to kind of reflect on that, and that's a sobering reality, and we need to kind of maybe change, and I think we are doing that, and you're going to hear some amazing talks from fabulous speakers on the new progress that's been made in trials and therapy development. I think it's also worth just thinking about actually the licensed therapies that we have. Who do they actually work in, and who have they been even tested in? So we have 2 licensed first-line therapies, as most people know. One is combination chemotherapy, that's platinum pemetrexed, that was proven in the Emphasis trial. And then we have combination immunotherapy, which is Ipi/Nivo, which was proven in Checkmate 743. And I think it's useful to just look at those studies and look at the patients that were involved. And you can see there that the vast majority of patients in those trials have late-stage mesothelioma, stage 3 and 4. And I think that, as I'll show you, doesn't necessarily translate to the majority of the patients that come through our services. We have lots of patients who have stage 1 disease, and actually these trials really didn't include sufficient numbers of patients of stage 1 mesothelioma to be confident that those therapies are suitable and are a good balance of benefit and risk. And that's reflected in the licenses for these agents in the UK and Europe and the US, which are all for unresectable disease. And I would personally advocate for us to move away from using terms like resectable or unresectable and start to talk about stage in the way that we do for every other cancer. It's also sobering to look at real-world studies of Ipi/Nivo. Ipi/Nivo can be effective and really transformative in some patients. But in reality, the outcomes in the real world of overall survival have certainly been less impressive than they were in the licensing studies. And many of our patients have to stop because of really meaningful toxicity. So we do really need better therapies. It's also, this is data from the National Network in Scotland, where we just published this data in thorax in the last few months, looking at outcomes, at the impact of a national network. And this is just a stage breakdown. And you can see, if we just look at the numbers of patients, these are consecutive diagnoses in Scotland over 6 years. They're going to reflect roughly what we see in many other territories. That only maybe 45% of cases have stage 3 and 4 disease. And actually more like 50% of cases have stage 1 disease. And we really have limited options for these patients now with the publication of the MARS-2 trial, which we think we've all read, and many of our patients will also have heard about. Unfortunately, the MARS-2 trial showed in the UK setting that the use of aggressive therapy for earlier stages of disease was unfortunately not associated with any benefit, and did appear to be associated with an inferior survival. In the same journal article, we published this viewpoint article, an international consortium of authors, many of whom are on this call, highlighting the potential of an alternative strategy in early stage disease, and that's to use intrapleural drug delivery to maximize drug tolerance and maybe give local therapies. And I think that's an untapped area of research. I think what we don't know, and this is kind of remains frustrating is actually how mesothelioma develops after asbestos exposure. We know some of this story. We know that there's a long latency between exposure and disease occurring. We even know that there's a precursor state in some patients who appear to present with a benign asbestos-related effusion. And we know those patients are at risk of developing mesothelioma in the next couple of years. But the sequential steps that take you from asbestos-related chronic inflammation, non-specific pleuritis to mesothelioma and how we might intervene are still not completely understood. And we know from animal models, this cartoon summarizes some work in an asbestos-exposed mouse model. We know that if you expose a mouse to asbestos, then you get a series of molecular events where you get changes in the genome inside the cells, where you get hypermethylation at different sites of the genome, and then you get loss of some of the classic genes that are lost in mesothelioma. So we know there's a stepwise process, but we don't understand this well enough in humans to actually be able to intervene. And that question really is the focus of this international accelerator program that I have the great pleasure of running, called Predict Meso. Predict Meso is an international program that was funded by Cancer Research UK and its partners in Italy and Spain. You can grab that QR code using your phone and you could go and look at our website and see what we're doing. But as you can see there, the consortium has grown to include most people involved in the field, I think, and over 200 investigators now in 130 institutions in 17 countries. And the aim of Predict Meso is to build unique human tissue cohorts that map the transition from pre-mesothelioma benign inflammation into mesothelioma, so that we can use that material to understand how mesothelioma develops, and we can therefore design more effective therapies, particularly therapies that could be given to patients with early stage disease, and even therapies that could be offered to patients who've got high risk pre-mesothelioma in some sense. I don't have the time to go through the program in any detail at all, but there are these 5 integrated work packages that you can see here very quickly. The first work package is really focused on coordination of the network, but probably a major part of that work has been the collection of the completion now of Meso Origins, which is a large multi-centre study where we have 32 centres in the UK recruiting patients with suspected mesothelioma or pre-mesothelioma. The study will close in about 6 weeks, and we will recruit about 600 patients in that time. And we're using the tissue that's been collected to identify new targets for disease. This cartoon here, this image here describes transcriptomics, so gene expression data, and these are human data, and you can see interspersed with the human data, you can see some red arrows that correspond to genetically engineered mouse models. So we have models of disease in the lab that replicate really the human disease. We also have a number of labs across the UK and Europe building new cell lines and organoids, and genetically engineered mouse model has been used to test new therapies. And we can deliver asbestos into the pleural space of the mouse and then switch off the genes that cause mesothelioma in that mouse and then deliver treatments to that mouse. And you can see some published data here showing survival benefit in the mouse model from different therapies. And we're also developing tools for clinical trials, including the image that you see there is a CT scan that you can see shows a mesothelioma on the right side with a large effusion. And we're using artificial intelligence to automatically segment the tumour, which is shown in red, and give us a size measurement that we can use for future trials. So how do we translate these discoveries into new therapies? Well, in Predict Meso, we are trying to build better laboratory models that replicate human disease, and that the lack of those models may, to some extent, reflect the poor translation of previous laboratory results into actual licensed therapy, which when we put them into patients. We are sharing all of the resources that we generate, so anyone in this call can apply to Predict Meso and get tissue or data or images. But we do need better clinical trial designs, I think, and you're going to hear from some of the leaders in the field on biomarker-enriched trials. And I think we need to think about better endpoints. Some of, I think, the reasons that our trials have failed is because we can't measure response very accurately. And I'll suggest how we might do that on the next slide. And we need trials of early stage disease. We also need to do more of this, which is large scale global collaboration. It's very hard in a rare disease to run trials of sufficient scale in one location. And when we do that, they're slow and we need to move more quickly. And there are different ways of doing that with efforts that I'll mention with involving IMIG, which Anna leads. And one of the impediments, as I've suggested, to trials reading a positive result is not just that the drug therapy we test maybe worked in a mouse but isn't going to work in a human, is actually that the measurement tools that we use have been really quite poor. We use something called modified RECIST, which is a way of radiologists measuring whether a tumour is growing, and that measurement is very challenging for a human to do, but we now have AI solutions that allow us to generate these sort of 3D volumetric estimations of tumour size. We published the first tool for this purpose now back in 2022. And many of you will have seen the publication of Artemis last week in Lancet Oncology, which has now validated that technology at a very large scale and shows really high levels of surrogacy between overall survival and volumetric PFS. So we need to use these tools now in clinical trials. And finally, this global collaboration that I think we're doing today is so important. And one of the shared goals of IMIG and Predict Meso is to assemble international cohorts and use those international cohorts to compare different standards of care and to do clinical trials in a new way, potentially involving synthetic control arms and bringing industry more efficiently into the work that we do in the academic sector. And just before I finish, it would be remiss, I think, if I didn't mention network development as just a final thing that I think is really important for us to improve outcomes for patients. We all know that mesothelioma, in terms of its incidence, is quite heterogeneous. You can see the UK map that shows hotspots, but lots of cooler spots, and that makes it difficult for expertise to exist everywhere. And so having a network model of clinical care is important. Also helps us do trials. In Scotland, we put that in place in 2019, and you can see the team here and the hub and spoke model that supports. And we've shown over the years since improving quality performance indicators that we publish on a yearly basis. We've now embedded that network in routine standard of care funded by the government. And we've just reported a few months ago in Thorax improving survival with the development of that network. And with support from Meso UK, we've now been able to provide funding to pump prime those network operations in the rest of the UK. And so that, I think, is a model that we should try and adopt just for better care more generally. So I'll finish there. And I'll hand back to Liz. I'll stop sharing.
Thank you, Kevin. And we did make up, I think, a minute maybe. So that was good. Amazing showcase of international collaboration and what can be achieved. I think 17 countries, 200 odd institutions is just fabulous. And we need more of that. So no questions, Kevin. There is a comment in the chat from somebody asking more about BAP1 germline predisposition, and I've put the link for the Meso UK leaflet about that. And of course, we'll be happy to answer any one-to-one questions if you want to email separately. And then also another comment about how entering a clinical trial with Ipi-Nivo gave somebody a survival of 18 months. But not only that, the comfort knowing that that really helped other people being part of a clinical trial. Kevin mentioned at the end of his presentation about the Scottish Mesothelioma Network and working collaboratively in a team across a country like that really does reap benefits. And our next speaker is going to show some more insight into that. We're so lucky in the UK that we do have a national team for peritoneal mesothelioma, and that team is headed up by Tom Cecil. He's a consultant colorectal surgeon working in Basingstoke, and he's the clinical director for the Peritoneal Malignancy Institute that's based there. And Tom's going to talk to us about the UK peritoneal mesothelioma team. So over to you, Tom. Thank you.
Good. Well, thank you very much, Liz, and thank you everybody for inviting me to give this talk. I'm Tom Cecil. I'm a colorectal surgeon, and I work at the Peritoneal Malignancy Institute in Basingstoke with 8 other consultant surgeons, where we provide surgery for cytoreductive procedures to try and deal with peritoneal disease. This is the type of surgery we get up to. CRS refers to getting rid of the tumour, and it's the combination of peritonectomy procedures where we remove the peritoneal surfaces and visceral section of affected organs. So here is the peritoneum from the parachoric gutter taken with this thick rind of peritoneal disease. This here is a pelvis that has been cleared. This is the bladder with all the peritoneum taken off it. This is a female patient who's had a hysterectomy and their rectum out to completely clear the pelvis. This is small bowel, where we've taken all the peritoneum off the small bowel mesentery, which will take us a couple of hours. And this is often a challenging area in peritoneal mesothelioma where there's involvement of small bowel. Here we're destroying all the disease on the surface of the liver with a high power cautery to do a liver capsulectomy. This is a stomach where all the omentum's been removed and is surviving on the left gastric artery. And this is the hypec, where one of us stands for an hour and washes the tummy with hot water with chemotherapy in to try and get rid of cells and microscopic disease that might cause things to come back and progress in the future. So peritoneal mesothelioma is rare. We think there's probably about 90 cases a year in UK and Ireland. It's a small proportion of the mesothelioma cases compared to pleural mesothelioma. There's probably less of a difference in men and women than there is with pleural disease, and it probably is related to asbestos, but the links aren't as strong and clear. So how do we get involved? The main condition we treat is appendiceal tumours, pseudomyxoma peritonei, and this is an appendix here coming off the cecum with a mucinous tumour at the end with jelly coming out. And this will spread in the tummy to the ovaries, give these very large Krukenberg tumours, can spread to the omentum, and you get widespread peritoneal disease. This is a patient with cystic mesothelioma, and you can see that things aren't that different. And if we're honest, the reason we got involved is probably by mistake to begin with, that we couldn't really tell the difference radiologically between these big masses. And we got to refer patients with big tummies, and we would look to remove the disease. And we published on the early outcomes of this, 17 patients over a 9-year period, so a really rare disease. We were able to remove all the disease in 8 of those 17 patients, and they had a median survival of 4 years versus a year in patients where we left disease behind. So it seems it's important to try and select patients where we can remove all the disease from the abdomen and clear things out. So we rely really heavily on our radiologists to help us with this, and they have something called the PAUSE score, which helps us to try and select patients where we might be able to remove peritoneal mesothelioma from the abdomen, and they focus on different areas. The P stands for the Peritoneal Cancer Index, which is a scoring system of the different areas of the abdomen and small bowel, with a grading of 1 to 3, depending on the amount of disease, give an overall score of the amount of cancer in the abdomen. We score whether ascites is present, whether the abdominal wall is involved for the A, This is really important, the unfavorable sites of disease, so areas where we know it's going to be technically challenging to be able to remove the tumor, and there's some areas where we know it won't be possible. The small bowel is a very important area for this, and the involvement of the small bowel, and whether there's extraperitoneal metastases. And these are some of the U2 sites. So if there's biliary obstruction due to tumor, celiac axis involvement, the retroperitoneum involved, the root of the small bowel mesentery, extensive involvement of the small bowel or sidewall nodes or disease on the sacrum, areas that will make it difficult for us to remove the tumor. And these are some examples, scans with the small bowel pulled to the back of the abdomen. We know it's going to be grossly involved. Disease on the small bowel, we know we won't be able to separate it. This thing called a stellate mesentery, we know we're going to find a frozen small bowel that we can't remove the disease from. Disease at the root of the mesentery, pelvic nodes, sacral disease around the porta hepatis in the liver here, and epiphrenic nodes in the chest, retroperitoneal nodes, things that will stop us being able to remove all the disease, which we think is important to benefit patients and how we select patients. So this is really a timeline of what's happened in Basingstoke. We were appointed in 2000 as the National Centre for Pseudomyxoma Peritoneal. We were commissioned, which meant we got paid for the cases. This is extensive surgery, which requires a lot of resources with intensive care, long inpatient stays, so financial burden on the organisation. And as I mentioned, over about 8-9 years, we did some cases of mesothelioma, really as we weren't so clear as to what was going on with patients. But we got commissioned in 2011 for mesothelioma. That this treatment would be provided for selected patients with mesothelioma, the cytoreductive surgery, and the heat intraperitoneal chemotherapy. In 2013, NHS England was formed, and they commissioned colorectal peritoneal metastases, which is colon cancer that has come back in the peritoneal cavity. But at the same time, they decommissioned mesothelioma, which meant that it wouldn't be routinely commissioned or paid for. In response to that, we set up the National Peritoneal Mesothelioma MDT, as we had existing patients in the system. We had patients waiting treatment, patients we'd operated on, and we weren't really quite sure how we would manage these patients when we were told we could no longer treat them. This is the commissioning document supporting colorectal peritoneal metastases, and the letter that said the following treatments will not be routinely commissioned. The only cancer treatment was cytoreductive surgery with hypec for peritoneal mesothelioma. So the National Peritoneal Mesothelioma Multidisciplinary Team meeting was set up. It was a video conference established with centres in Basingstoke, Manchester, Birmingham, and Dublin. The Birmingham and Manchester centres now no longer provide the treatment, and we provide the treatment in Basingstoke, and the Mart Hospital in Dublin will provide this treatment for mesothelioma. We hope to centralise resources and expertise, try and address the variation in practice and give access for patients, optimise selection and treatment strategies, and collect data to try and appeal the commissioning decision. So we over time have seen more of the patients. This was the National Mesothelioma Report from 2018-2020, and you can see we went from 14% to 29% of peritoneal mesothelioma patients being discussed. And we think we're now probably around 50-60% of patients who will get referred to us for an opinion. And those actually going under surgery remain a small proportion. Under 10% of patients we will find are suitable for surgery. One of the really key appointments has been Sam Westbrook, who we appointed as the first UK dedicated peritoneal malignancy nurse specialist. And this post was fully supported and funded by Mesothelioma UK. And Sam has been a fantastic resource for patients, clinicians, relatives, and she does a lot of education, support, workshops, and a real source of knowledge and coordination for the service and patients. and she organises the MDT that's gone from being a monthly event to now it's a fortnightly meeting. We've been lucky to get one of our oncologists interested, Marcus Riemer, and he clearly can't treat the patients as they need their treatments locally, but he can help us in the decision making, give us guidance and give guidance to referring teams on treatment options if they're not suitable for surgery. What we've really found is that the peritoneal mesothelioma forms into two main groups, that the low malignant potential and the diffuse malignant peritoneal mesothelioma. And the pathology is really key and sometimes quite complex, and getting expert pathology is important. And the diffuse tumours are more aggressive and are less likely to be suitable for surgery. The low malignant potentials will do well, but a lot of them don't need surgery, and it's selecting who needs surgery and who may benefit. And this is examples of low grade. This is a multicystic mesothelioma, and you can see that the patient here would clearly be symptomatic, so it's not a completely indolent tumor, but but they'll benefit from surgery and they'll do well. This is well differentiated papillary mesothelial tumor, which again can come extensive, but they're going to do well and it'll be easier to remove, and we're likely to achieve a complete cytoreduction. The epithelial malignant tumors are more widespread, more diffuse, and it's hard to achieve. They'll often have involvement of the small bowel, and will operate on occasionally on sarcomatoid biphasic, but they tend to be on more aggressive, recur, and not do so well. So looking over a time period of 6 years, we had 78 MDTs. It's interesting that we actually saw more female patients than male patients, and that's probably the influence of cystic mesothelioma, which is more common in female patients than male patients. The age range with our youngest patient was 11 years old with epithelial mesothelioma. I'll come back to that. So that covers a range of patients, but probably younger patients than pleural mesothelioma. The majority of patients we're seeing on histology are epithelial mesothelioma, followed by cystic mesothelioma. And there's often an overlap between these groups, and getting accurate pathology is important, and we will change the diagnosis on review. Of 421 new patients referred, 61, 14% went ahead with surgery with CRS and HIPEC, and the others we felt either didn't need surgery, weren't suitable for surgery, or been deferred till after they've had some systemic anti-cancer treatment. The age of the patients, mean age is 51, so a slightly younger cohort of patients we're treating with surgery. More female than male patients. Again, I think that probably relates to the symptomatic cystic mesotheliomas. And this PCI score I talked about, where the maximum score is 39, we're selecting people with a low score where we think we'll be able to remove as much, or if all the disease, if possible, to get a good outcome. They're long operations, 6 to 8 hours for the surgery. We're using doxorubicin and cisplatin for the HIPEC chemotherapy. We're achieving a complete cytoreduction where we can remove all the disease in just under 90% of patients with careful selection, and a blood loss of just under 1 litre for this major surgery. In this group of 61, we had no deaths, a 10% Clagian-Lindo 3-4 complication, and these are 3-4 are serious complications, things like return to theatre, intensive care, bleeding, things where you require intervention, but a lot of minor complications. So the majority of our patients will have some form of complication from this major surgery. The main pathology we're operating on is the epithelial mesothelioma patients, followed by the multicystic mesothelioma and few biphasic and papillary. In 4 of the patients, we found a different diagnosis. We'd got the diagnosis wrong from our initial assessments. one of them, in fact, two of them actually turned out to have pseudomyxoma rather than mesothelioma. Looking at the overall survival of the group where we intervene with surgery, unsurprisingly, they do better. They're a selected better group of patients than the patients, the rest of the patient group who haven't undergone surgery. But if we focus on comparing the low grades to the diffuse malignant mesothelioma, you can see that the low grade patients don't die from their disease. They will get recurrence with the diffuse malignant mesothelioma, the majority of patients will recur, but we do get some long-term disease-free survivors. We found that Ki-67 proliferation index is an important marker for the diffuse malignant mesothelioma, and those with a low Ki-67 proliferation index do better than those with a high index, but it's not a definite marker that we would use as an arbiter to decide on surgery. It's given us an opportunity to collect data and do research and publish on this rare disease. We probably learned a lot about the cystic mesotheliomas, that probably the indication to operate is symptoms. A lot of patients will have pain from the condition, and that's not something we probably cure with surgery. But once people get symptoms with distension or compression symptoms with bowel or kidney failure, then they do well with intervention, and some of them will be cured by that. Some of them, the disease will come back. We've learned about presentation, how we classify and manage the disease, and outcomes. We've been supported by Mesothelioma UK to do some genetic studies, and just recently published on the genomic sequencing of multicystic mesothelioma, where we found some mutations were associated with recurrence, and they were mutations which are related to malignant tumors. So the suggestion that this isn't quite an indolent benign tumor, that there's some malignant potential to cystic mesothelioma. The future, I come back to our 11-year-old patient. She was a pediatric patient, so she had a tumor sequenced, and she was found to have an ALK mutation and given seratinib on compassionate grounds. Prior to that, we had assessed her for surgery and felt she was completely inoperable as a laparoscopy, but she had a fantastic response to her seratinib, and then came for surgery, had a complete size reduction where there's just one tiny focus of epithelial mesothelioma left, and she's done well so far. PIPAC is a new treatment that's evolving, which is a pressurized intraperitoneal aerosol chemotherapy, which is put in at laparoscopy and could be very suited to mesothelioma patients. There's a big UK trial called PICOS, which we're involved in. We hope that will lead to being able to offer this treatment for patients with mesothelioma. And we've looked at the national commissioning and applying again. We resubmitted an application in 24 and unfortunately got turned down again for funding for the treatment. And the attached clinical panel report highlighted immunotherapy and said that really with the advent of immunotherapy, there really wouldn't be a need for surgery. So we looked at what's happening to the patients who are having immunotherapy with peritoneal mesothelioma. 318 patients who were discussed, 109 we thought would benefit from considering immunotherapy, and 2/3 of these received immunotherapy. Some of them had chemotherapy before, some of them chemotherapy afterwards, and the majority had dual immunotherapy. We looked at the symptoms, and just under half of the patients had side effects, and the majorities, it led to them stopping their immunotherapy. It did work in about half the patients, and they didn't progress. In some patients following their immunotherapy, we went ahead with surgery and operated. So again, it seems that the patients are getting immunotherapy, but not all of them, and it's not well tolerated in all patients. So in conclusion, we found that this centralized MDT helps us with patient selection and management of rare and complex disease, allows us to collaborate well with teams across the country. Selected patients will benefit from surgery with cytoreductive surgery and heat intraperitoneal chemotherapy with good outcome potential for cure in some. And we feel that the data we're collecting hopefully will support the need for national commissioning of this treatment for peritoneal mesothelioma. Thank you.
Thanks very much, Tom. That was fabulous. I don't see any questions in the chat, and just to remind folks, if you do have a question, then you can either ideally pop it in the Q&A box, but you can use the webinar chat if you like. Just one comment, and Tom, just in the interest of time, we just have one quick question. I think we are very grateful to the input that you've provided to our patients in Scotland, and I think I'm sure across the UK, others would echo that. It's obviously a challenge in a rare disease to generate the robust evidence that we would want for these big interventions. What's the appetite in the kind of global peritoneal community for randomized trials that involve surgery to get over some of these hurdles around commissioning evidence and building cases for these things? Is there an appetite to do those trials?
There has been some collaboration to collect registry data internationally, which we've been part of. One of the things we're really lucky in the UK is because of the pseudomyxoma approach to having 2 commissioned centres. This surgical approach is limited to a few hospitals, whereas in a lot of countries, lots of hospitals and surgeons would be doing it. And then for a disease like mesothelioma, it becomes 1 or 2 cases at best every few years. So it is hard to coordinate those sorts of randomized controlled trials. I think when we last looked, we in the UK have 3 centres. In the States, there's something like 150, 170 centres doing CRS and HIPEX. So when you spread that workload of mesothelioma out, it's hard to see how you'd establish those randomized trials. We're looking at sort of ways we could do it, and perhaps have different arms of a trial that patients can start their journey in and move across and collect data and see how if there's other models that we could work to try and get some better data on this.
Yeah, I mean, maybe some of the global cohort assembly that we're trying to do through IMEG and Predict Meso might support some of that if we made sure that we included peritoneal cases, and we could have maybe try and move that forward. But I'll move on if that's okay, Tom, just in the interest of time. Thanks so much for your fabulous talk. I'll hand the mic back to Liz.
Thank you, Kevin, and thank you, Tom. Fabulous talk. And as I said before, we're so proud of our peritoneal team, national peritoneal team in the UK. The next speaker is Leah Taylor. Leah is a senior nurse specialist in the northeast of England. She leads the National Mesothelioma UK network of nurses, which Sam Westbrook, who Tom spoke about, is a member of. And Leah's going to talk to us about the role of nurses, and she's just got 10 minutes to do that. Thanks, Leah.
Thank you, and thank you to the organisers for asking me to speak today. Can you see my slides okay? Yeah, lovely. So, yes, I just want to give really a quick overview and awareness of the mesothelioma nurse role in the patient's journey. And I know, this is a global forum across the world. There'll be lots of different models of nursing and how that's delivered. This focuses on how we've developed that in the UK over recent years and what our current system is. So in order to understand the importance and the role of mesothelioma nurses, it's helpful to consider the wider development of the nurse specialist roles within cancer care. And within the UK, these were introduced into cancer in the mid-1990s and had been established in other conditions before that. But really, they became central to the concept of having this sort of named nurse to call on to guide through the cancer pathway, and sometimes called key worker. It's fair to say it's taken some time. I've been a clinical nurse specialist for 20 years. It's taken some time to embed these roles, and there has been considerable variation in the role, in responsibilities, and in grades of nurses. But more recently, the Ascend framework has given a more structured approach to nurse specialist development so that nurses are able to map their progress across sort of four levels of that framework. But it's fair to say that many of the developments are focused on the most common cancers, so lung cancer, bowel cancer, breast cancer. And the clinical nurse specialist roles within these cancers are now far more developed. And in the UK, care of people with mesothelioma has historically fallen under the remit of the lung cancer nurses. So why do mesothelioma nurses matter? Well, as I said, mesothelioma is often included within lung cancer just because of its thoracic presentation, but we know that mesothelioma is a distinct disease with unique diagnostic and treatment challenges. And we know that the needs of people with and affected by mesothelioma are different to those of people with lung cancer. And as a rare cancer, many healthcare professionals may encounter very few cases, which can make it very difficult for those people in those teams to provide specialist support. So dedicated mesothelioma nurses provide expertise and continuity that's difficult to achieve in mainstream services. And some of that, not least, is due to the massive expansion of the lung cancer nurse role because of, new treatments, so many new and emergent treatment pathways. And as a former lung cancer nurse myself, I would say it is very difficult, I think, to keep on top of what's happening in lung cancer and emerging in lung cancer, never mind to keep on top of actually what's happening in mesothelioma at the same time. Mesothelioma nurses, because of their understanding of the disease, they provide much needed symptom management and have a real deep understanding of the financial and legal issues associated with mesothelioma. So Mesothelioma UK have developed this hub and spoke model for providing support across the UK, and we have coverage, as you'll see by the map, we've got coverage in all 4 nations. I suppose what can make us slightly different is that our nurses are fully embedded within our National Health Service, which ensures that their feet remain fully grounded in clinical practice. And so they are aware of the issues facing clinical teams, but also patients and families as well. Although it may not appear so on the map quite so much, there are still gaps across the UK in coverage, and a lot of the work of Mesothelioma UK ongoing is to try and make sure we have equity of access to mesothelioma nurses across the UK. So a significant part of the nurse role is direct patient care, which is, probably not a surprise. And our specialist nurses probably or usually become involved at the point of diagnosis, or sometimes, pre-diagnosis, guiding people through those initial investigations and that really uncertain time to diagnosis. And then they remain a constant, usually through treatment and potentially into advanced disease. The nurses manage their own clinical caseloads and coordinating care and acting as core members of the MDT. And advocacy is a vital aspect of their role, helping patients to understand their treatment options and to support informed decision making. And as I said, nurses have expert knowledge in the treatment options in clinical trials and really strive to ensure that patients have equitable access to treatments and clinical trials wherever possible. And as I previously mentioned, that in-depth understanding of the disease means that they provide expert symptom management, sometimes meaning that palliative care services don't necessarily need to get involved or don't get involved so early because they understand and know how to manage these symptoms. And they also understand all those sort of intricacies and nuances of the financial and legal side of this disease, which just brings an additional complexity and an additional burden to people and their families. So beyond the clinic, I guess, is the bit that a lot of people don't see. And this is where mesothelioma nurses sometimes perhaps have a different role to other specialist nurses. And that comes with working across a rare cancer and working with a charity to raise awareness of that rare cancer. So the role extends far beyond the clinical. So all our mesothelioma nurses are part of support groups, and some run and facilitate those groups independently. And support groups are an essential part of supporting people to live well outside of the hospital setting. And as I say, often that's quite unseen, among clinicians. They become regional experts for other healthcare teams to link into and share knowledge. And often within the UK, we have cancer boards and networks that Kevin's talked about, and cancer alliances, and the nurses form a really integral part of that, usually becoming the mesothelioma representative on those. Generally, they're still embedded within lung cancer, but at least mesothelioma is represented, and those nurses have a key role in making sure that mesothelioma remains on the agenda and is not a forgotten disease. Education is a major component of the nurse role, and in improving awareness and helping to build expertise across the NHS, and helping the teams to understand where to come to for help. Many nurses are involved in service development and improvements that might be within their own organisation. It might be looking at care across their region and identifying gaps in care and suggesting strategies to improve that care. And this is all encompassed within the role. All of our nurses help to deliver our national support line, so they respond to calls, emails, Facebook messages from across the UK, but also internationally as well. We do get a number of international queries, and we always have a nurse available Monday to Friday to support any patients, families, or healthcare professionals with any queries that might come up. And a lot of these activities are much less visible than the direct clinical care, but and as such, that's really difficult to quantify, but the impact is really substantial. So I've highlighted just 4 cases where mesothelioma nurses have gone above and beyond to deliver exemplary care to their patients. I'm not sure if my little infographic, yes, it is going to work. So in the first example, we had one area in the country, and I think Anna mentioned this in her talk at the very beginning about sort of the inequity of access even to immunotherapy. And we've certainly seen that within the UK. And there was one area of the country where people were having to travel a considerable distance to access first-line immunotherapy. And that just brings additional burden that people don't need. And so one of our nurses was able to work with the local oncology teams and to negotiate and really kind of advocate for this, for mesothelioma patients to establish immunotherapy within their local hospital, meaning that patients didn't have to travel so far. Second example was, again, a patient who wasn't being offered immunotherapy locally, had been offered chemotherapy, and there was really didn't appear to be any reason why immunotherapy wouldn't be suitable for this patient. And by linking in with the nurse and with Mesothelioma UK, that enabled the patient to, and it facilitated a referral to a different centre so that the patient could actually receive the treatment that they wanted, and expand the treatment options than they were being offered locally. The third case was a lady who was moving from one end of the country to the other, and as luck would have it, there was 2 mesothelioma nurses in those, one in each centre, and so that ensured that that lady, she'd just started treatment prior to her move, in the week prior to the move, so that ensured that that lady could move house, get registered with a GP, had an oncologist, had oncology slots for treatment, and there was no break in that treatment. So that clinical network of mesothelioma nurses really ensured that patient's treatment continued as we'd wanted to do. And finally, and Tom mentioned about the work of Sam Westbrook, our peritoneal nurse specialist, and this Sam, as a rare cancer nurse, but in an even rarer form of a rare cancer nurse, recognised the unique needs of people with peritoneal mesothelioma in terms of that support and needing to be able to talk to other people in a similar situation, and developed a support group and a buddy system, which has been so beneficial for so many people. And these are just 4 examples of many other examples that I could give you, and really often fly under the radar and are very unseen, but they make such an enormous difference in the patient's journey. So I'd like to finish by sharing a quote that I actually received recently from one of my patients. And for me, this captures the essence of specialist nursing. Patients may not remember every detail of their pathway, but they do remember who listened, guided, and stood alongside them in their time of need. Thank you.
Well done, Leah. That was fabulous.
Thank you.
It's a kind of great overview of the role of the nurse specialist, and I think many of us who are lucky enough to have a meso nurse specialist with us kind of would echo those final comments. There aren't any particular questions, and I wonder, getting the interest of time, just because I think it's really important that we have enough time for our specialist support groups, which are going to be next. If we could move on to that and just hand that back to Liz to kind of chair that session, if that's okay.
Yeah, fabulous. And hopefully we will try and finish on time at 12:45. Because of the delay in time, I'm not sure that Tracy Wood will be able to join us, but and Russell's going to control the slides for this for each of us. So I'm really lucky that Leah and the nursing team are my closest clinical peers, and it is a fabulous nursing network to be part of. But I'm also really lucky that there are organisations like Mesothelioma UK across the world, and we've picked just a few today that we really do collaborate with quite regularly to showcase, because we think it's important for clinicians to know that we are there to support you in your practice, and it's really important for patients to know that we are there to support you and to give voice to your experience and do what we can to change the status quo. So of course I'm going to start with Mesothelioma UK and just give you, so we've had this is just 10 minutes. Each presenter has got 1 slide and 2 minutes to talk about their organisation. And then if there are any questions, then Kevin can pose them very briefly, but hopefully we should finish for 12:45. So Mesothelioma UK was founded in 2004 in the UK. It was born out of and is completely embedded in the NHS. And I think the fact that, Kevin has spoken about Meso UK, and he's on the board for Meso UK, and we're very, very much integrated into Scotland. And then Tom has also paid reference to it. I think you can see that we really are working alongside our clinical teams to do everything we can to improve the care that's at the coalface in the front door of the National Health Service. Our annual income is currently about 1.7 million, but that's grown from just a few 100,000 up to that over 20 odd years. And I'd like to think that we've really become well known as the hub of the UK mesothelioma community for clinicians, advocates, patients, families, and everybody really. We try to be a one-stop shop for mesothelioma. We provide all the things that other health charities and cancer charities particularly provide in terms of information in all sorts of forms. We've got webinars, podcasts, written information, our website, and we also try to personalise and give one-to-one, and we've got our support line. We try to be there and walk the journey with patients and families, and we try to be there to support clinicians as well. It's not easy trying to maintain your expertise in a rare cancer when you're working in a really busy service. So, we really want to support our clinicians as well as patients and families. We fund research and clinical audit, and then work really hard to close the loop between that research and audit findings back into clinical practice, and empower patients with the knowledge as well about that. We provide lots of educational opportunities. We try to give voice to patients. Advocacy has not been at the forefront of us as an organisation, because we've been very focused on clinical care and support, but more recently have really tried to work hard to give voice to patients and engage with policymakers and politicians to try and, as I say, to change the current status quo in terms of exposure, awareness, services, treatment and care. And we also provide grants for not just research and clinical audit, but for clinical teams. Kevin spoke about the clinical networks, and we've recently awarded some grants for clinical teams to develop their own networks. Our tour de force are our nurses, and I think you can see from Leah's brilliant presentation the extent of what they provide. And they are described as a tour de force by our colleagues, and I'm really proud to be a member of those that nursing team. There are 30 of them currently, and we probably need another 10 or so to cover the whole country. The organisation is based in Leicester. We were born out of the University Hospitals of Leicester, and that's where I still practice clinically. And really that's it for Meso UK. So I'm going to hand over now to Kim. Kim Brislane is the Chief Executive of ADRI, and Kim's going to tell us about ADRI.
Great, thank you, Liz, and it's just lovely to be with everybody. Your today, my tonight. It's very late in Australia. I'm coming to you from, there's my slide. I am actually coming to you from Canberra, where I've spent today at Parliament House. One of the pillars of ADRI, the Asbestos and Dust Diseases Research Institute, very much is advocacy and working directly with politicians, policymakers to push as much change both federally and state. What I will talk about, though, very briefly here is the work of ADRI. Outside of that, we are the World Health Organization's collaborating centre for the elimination of asbestos and dust diseases. That is a fairly hefty piece of work. We spend a lot of time training health specialists across Southeast Asia, and drawing on Anna Nowak's point about the importance of really training health professionals. And we were very lucky to have Liz come and train with us in Cambodia last year. We train nurses, we train doctors, we train GPs, oncologists, radiologists and pathologists, because in these countries often they will say we do not have an issue with asbestos, and it's simply because they cannot diagnose them. So at home, the Australian landscape is fairly complex, federated model, but I've included the number here and I've remained at 2020, 870,000 mesothelioma deaths. It doesn't really change that much in Australia. We talked about the lag in data, but we are experiencing increases across different sorts of mesothelioma all of the time. At ADRI, I work with researchers, scientists, I work with clinicians, I work with nurses who deliver psychosocial support, and I work with public health experts, all who deliver for ADRI across a range of areas. Our support service, we only have one full-time equivalent nurse, and it's Pam and Carmel who do the most extraordinary job. We have around 300 over 300 families and carers supported. That's over 2,000 episodes of care. And just an interesting piece of information, we've had more new referrals in 6 months this year than we had in all of the year last year. So that is why we're always very concerned about the numbers that we are getting through the registries. In terms of the projects we run to directly support patients and their families, we launched Dust Disease Diaries. Our podcast is now, we've just filmed the 31st episode, around 4,000 streams. It's available across all streaming platforms. So Dean Fennell, I know, has been on it. We talk to patients, doctors, anybody who's in the coalface. I really encourage everybody to listen to that, so I can put that in the chat. We've just launched Mesothelioma Hour, which is the first online support group in Australia. We have around 50 participants each month. In terms of training nurses, we developed Could It Be Meso module. In Australia, there'll be specialists around lung cancer, but mesothelioma is not as well recognised as it could be. So we've developed that platform and we share that with most hospitals across Australia. Over 110 nurses trained. And most recently this week, we have just launched the new guidelines and recommendations for the management of pleural mesothelioma in Australia. The last guidelines were launched in 2013, so most necessary. And we were really proud to be able to release those in Australia this week. That is my Cook's tour of ADRI. Thank you so much.
I did say it was a quick fire. I did say it was a quick fire round, and I'm going to move quickly to Linda, who's from the ADAO. Linda is the co-founder and chief executive of ADAO.
Good morning from Los Angeles. I invite you all over for coffee. It's just about 5 o'clock in the morning here. Thank you, Liz, for giving me the opportunity to introduce ADO to those people who haven't heard about us. For 20 years plus, we've been doing evidence-based advocacy. We believe education and advocacy and community are monumentally important to patient care and also the family. What makes us unique and different, I think, is we recognize that prevention, while promising research continues, prevention remains the only cure. So we have invested so much time in prevention to understand legacy asbestos, other pathways of exposure, but also use our voice and the science to make sure lawmakers, institutions, and others understand. Every year, 40,000 Americans die of a preventable asbestos-caused disease, which puts us in a unique position to also admit we don't have a comprehensive ban. Our ban is sitting in the Fifth Circuit Court, which some people might think, why? Money, power, and politics has played a big force in the United States. But we don't sit there, cry, and whine. We work hard to collaborate, communicate, and work together to advance education. And I'm really proud of some of the resources. You'll see on the slide, there's a QR code, and I'll build out a research page for tomorrow, Liz, and include IMIG and your materials. Because I think collaboration, nobody has a one-sided, lopsided feeling like owning the space. We all work together because no one should be left alone. No one. Alan's diagnosis and death led me to this pathway, and I really believe that the nurses at Meso UK, they provide such a service because when Alan was diagnosed, thinking just professionally and personally about this, is we're left in a medical system that doesn't really embrace patient care, especially the way Meso UK does. So Liz, you've done a phenomenal job. Some of the resources I just want to very briefly touch on. If we can't cure the disease, we need to invest in prevention, and that's what ADO has done. So on our website, you can find, for instance, the Asbestos Navigator. We're big on using technology and busting down all barriers and boundaries because we don't believe any of them should exist. No patient should suffer alone, and I think Liz and Meso UK and IMIG do a great job bringing information together. Every story matters. I hope some of you reading the chat, Gemma was talking about her mom in a trial and others with Kim, and of course Liz. Every story matters, and ADO collects those stories. We've put together a book, and many UK patients have their stories. So don't underestimate the power of sharing your story. When you're ready, ADO wants to help you share it. You're not a statistic. You're a true life story. And IMIG has a really important place in patient care. That was the first place when Alan was diagnosed in 2002. I'd never heard of mesothelioma and then learned that how steep the learning curve is, but also there was no cure. And IMIG and Dr. Bruce Robinson in Australia was my first colleague and friend, where he helped me to understand what I was facing. And I think people shouldn't shy away from embracing other countries and information because that is how we really find evidence-based, improved treatment, shorten the latency curve. So depending on where you are, this is obviously Mesothelioma Action Awareness Day, but I want you to think about the other 34,000, for instance, in America, of patients that die from asbestos-caused lung cancer. 34,000. So we and the other deaths, we think that knowledge prevents all. And there's a great time that we come together, and Liz has been such a wonderful leader. We do Global Asbestos Awareness Week, and I work very closely with the UK and unions in the US, etc. And we come together for a week of awareness. So this forum shouldn't end today when the speakers stop talking and slides are shared. I hope you'll all embrace the fact it is a movement, and collaboration is key to improving treatment and ultimately finding a cure. I hope I came in under time, Liz. I'm known for talking fast.
Thank you very much, Linda. Unfortunately, Tracy has had to drop off the call, but if you put Tracy's slide up, many of you will know how passionate I am about the work of the Glynis Gale Foundation. I've been a clinical advisor since the get-go and have visited Tracy in South Africa several times to support the work that they're doing. So Tracy Ward, who's sorry had to drop off the call, is the co-founder of the Glynis Gale Foundation. Glynis Gale was Tracy's mum. She died of mesothelioma a few years ago, and in her memory, and also I think inspired by the tragedy that's been left behind by the asbestos industry in South Africa. Tracy and her family established the Glynnisgale Foundation that works across 4 main areas, really: advocacy, education, research, and access to palliative care. They raise awareness of asbestos contamination and environmental exposure in communities surrounding former asbestos mines, particularly in the Northern Cape. And if you've never been, I really urge you, because a lot of the Northern Cape provided the rest of the world with a lot of asbestos. And unfortunately, it feels like the mines just shut yesterday. That's how devastating the situation is out there. The foundation works alongside local healthcare systems and the nursing school to improve palliative care training. And I've been into that nursing school and spent time there, and I've worked in the chemo suite there as well, supporting Tracy in that work. So please do look up the Glynnisgale Foundation, because it's it's a completely different experience, I think, for an advocacy and support group to those in many other countries. And our final speaker I'm going to pass to is Brian Lepacek, and he is the Executive Director for the MORF, Mesothelioma Applied Research Foundation.
Good morning, everyone, and thank you, Liz, for that introduction. My name is Brian Lepacek, and I'm pleased to lead the Meso Foundation here in the States. Just a quick highlight and overview of the work that the foundation does, both nationally and internationally. One of our primary reasons that we exist since 1999 is to fund research for mesothelioma. And so since 1999, we have funded over $12.8 million by granting research grants, peer-reviewed grants for research both domestically and internationally. Every year, that cycle includes grants that are up to $250,000, and they're awarded over 2 years. And again, it is a peer-reviewed process that is overseen by our scientific advisory board. And our 2026 pledge, that's a little typo in that slide there, is actually $750,000 to be awarded. And those awardees have been chosen, and they will be announced very, very shortly. So really leaning heavily into that investment. We know that we need to accelerate research and keep the momentum going forward for the organization and for the patients that we serve. On the education and support side, we do have an on-staff oncology nurse. Her name is Julie White, and she's actually on this call as one of the attendees. And Julie's role is really important to the organization in terms of how we support patients and families and caregivers and those folks in the bereaved community. She offers on-staff guidance on medical concepts. She helps folks deal with their symptom management. She is a key to providing referrals to specialists around the country, and also to helping patients make good choices about whether or not they are a candidate for a clinical trial. And so Julie really is that link that connects the patients to the science and to the clinicians. And we just really have been blessed to have her as part of our team. Our team also offers reimbursable travel grants to help patients and families reach meso specialists around the country, and also to support their participation in clinical trials. We find this to be a very key need within the meso community, especially since the centers of excellence for meso and specialists can be concentrated in certain parts of the country, and meso is not restricted to only one part of the country, as we all know. We also offer support groups of various types. We have a moderated Zoom and online support groups for patients, for caregivers, and for the bereaved community. Those groups are moderated both by Julie and by licensed clinical social workers. So really trying to, again, have that wraparound support that patients and families need when they're faced with this incredible journey ahead of them. We have an online resource also called Meso TV. It's our YouTube channel, and it contains expert interviews from across the globe and across various areas of meso in terms of treatment, in terms of clinical trials, and other, again, healthcare wraparounds that are just a great resource for folks to be able to access anytime, anywhere, from any country. And finally, we have an annual symposium that we host every year, and that also features experts from around the world. You have face-to-face access to talk to surgeons and researchers and clinicians and also really to have the meso community come together in support of each other, learn about the latest treatments, the latest modalities, and again, also to just continue that continuum of support and patient care that we know is so essential with the meso journey. And lastly, we do have an advocacy arm as well. And really, our main focus for advocacy is really maintaining the government support for meso researchers and for scientists, making sure that meso stays as one of those rare diseases on that list. So researchers can apply for funding through the government specifically to be able to access those funds to further their research. And so those are the main pillars of what the foundation does. And again, thank you, Liz, for your coordination of all of this effort. And we look forward to collaborating as best we can across the globe. Thank you so much.
Thanks very much, Brian. That was fabulous. And thanks to all the support groups, the advocacy groups who've given a presentation. I think in the interest of time, I think we're going to close the session there. I just like to kind of thank again all the speakers for the fabulous talks. We're quite keen to stick to the schedule, which means that we will be coming back in 15 minutes, which would be 1:15 in the UK. So just enough time for a cup of tea, or bring your lunch with you for the second session, or bring your breakfast with you, or your dinner, depending on where you are. So with that, we'll close this first part of the webinar and look forward to seeing you for the second part in 15 minutes.
Thank you very much indeed for joining us. My name is Dean Fennell. I'm Professor of Thoracic Oncology based in Leicester. And we have the theme this afternoon of therapy. We're going to start actually with Professor Shapril. I'm going to do the honours and introduce him. So Arnaud is a full Professor of Respiratory Medicine. He's been in that role actually since 2008, and is currently head of the Heart, Lung and Vessels Division in the Little University Hospitals. He trained as part of his doctoral training in the US and in Philadelphia, and has really since gone on to be a world leader in medical oncology and clinical trials. He's created and coordinated for many years the French National Expert Multidisciplinary Network for Mesothelioma, called NetMeso. And amongst his many other accolades, awards, he's had the gold medal for lung cancer awarded by the European Respiratory Society, and is very, very highly published in the field. Arnaud, thank you very much indeed for joining this global webinar, and take it away. Thank you very much.
Thank you very much for this very kind and long introduction. It's very nice, but coming from you, it's even more nicer. Thank you so much, my friend. So it's a pleasure to be among you today and to discuss quickly the pleural mesothelioma license therapy and the new phase 3. I had a few phase 2 because, as emphasized by Kevin before, there are a limited number of phase 3 trials in mesothelioma field. And I would say even it's the positive phase 3 trials are even much rarer. So hopefully you see my slides. So
yeah,
okay.
Yeah, perfect. Thank you.
Thank you. So here we are, my declaration of interest. I will just take a few seconds to make a tribute to my friend and colleague Marie-Claude Joran. Marie-Claude Joran, you may know her certainly because she was a great scientist, really dedicated to mesothelioma research all her life, a beautiful person, and she was also one of the two co-founders of IMIG with Bruce Robinson. So sadly, she left us very recently, and I would like really to thank her for what she did for us and for mesothelioma patients. So thank you very much for her and her family. So a vast majority of our patients are considered as unresectable pleural mesothelioma and or unfit for surgery. So I won't talk about this, and Joe Friedberg will nicely talk about surgery later. So I will focus on other therapy. So starting from the last European guidelines in 2001 from ESMO, there were a few licensed therapy in pleural mesothelioma first line, mainly so the usual chemotherapy with pemetrexed and platinum combination, plus or not bevacizumab based on our trial, the MAPS trial in 2015. But that did not lead to the validation of bevacizumab in many countries. So it's only restricted to a few countries like USA or France, for example. So it's one option. And the other option the option were distinguished only based on patient will and other comorbidity and performance status of a patient, not on histologic subtype at this time. So if the patient had a good performance status, so performance status 0 or 1, you could also propose the combination of immunotherapy, anti-PD-1, anti-CFO, nivolumab plus ipilimumab. In the other case, in patient with bad shape, you would propose best supportive care or depending on their will. So later, we recently confirmed the value of the combination of nivolumab and ipilimumab from the Checkmate 743 trial, as we showed the 5-year update data of overall survival. And this is really very nice because it confirms that the combination of immunotherapy brings really a benefit of survival after 5 years of follow-up, comparing 14% of patients still alive at 5 years with immunotherapy versus only 6% with chemotherapy. Of course, when we discuss with patients from family, we could not be happy with this number, and this is why we are trying to push hard all for research and new treatments. When you look deeply in the subgroup of patients, of course, as already reported, the non-epithelial patient seems to have a more interesting benefit of this immunotherapy because they did not respond well to chemotherapy. But still, in epithelioid subtype, we should emphasize that there was some benefit, even if it's less impressive, when you use immunotherapy versus chemotherapy. When you look at the benefit, it's mostly due to the duration of treatment in both groups. As you can see, the patient take advantage of the drug with immunotherapy much longer than with chemotherapy, with usually quite fast relapse in most patients. So in the routine, should we give immunotherapy to all patients? Well, as emphasized by Professor Dean Fennell already when we showed the first time this result, there is really a difference of balance for risk and benefit when you look at the subtype of mesothelioma. For non-epithelial patients, the benefit is so important compared to chemotherapy that it is overwhelming compared to the risk of immunotherapy-induced toxicity. For epithelioid patients, this is a more balanced risk. So really, we have to take account the benefit potential of the drug compared to what the patient could have for toxicity from immunotherapy versus chemotherapy. And also, I would say the profile, the pattern of mesothelioma patient. Interestingly, there were no new signal of toxicity after 5-year update. And now we have real-life data globally supporting this trial result. In fact, when you look at the data from real-life patients, real-life study, the toxicity is about the same than in the trial. So about 25% of patients having grade 3 or 4 toxicity. So it's something you have to take account and to explain to patients and relatives. And it may lead even to immunotherapy discontinuation in 25% of the patient. Only a few toxic deaths, but still you have to be careful and really train the patient as well as the clinical teams. But the good news was that globally the survival was similar to what we expect from the clinical trial, even if you have to be, I think, more careful when you look at the patient of 75 years old or older with immunotherapy. So after this trial, there was other phase 3 positive reports with, for example, the END 227 trial from the Canadian group with some other groups. And they showed that the combination of chemotherapy, standard chemotherapy plus pembrolizumab anti-PD-1 as first-line treatment may slightly reduce the risk of death compared to chemotherapy alone. But these results were not so good, I think, compared to the striking difference we observed with the combination of immunotherapy. And again, the benefit was observed in non-epithelioid patients, but not really, it was not significantly increased in epithelioid subgroups. So what I would conclude from this trial is that there is something in this combination of chemotherapy plus immunotherapy, because the objective response rate was really high compared to what we observe with chemotherapy alone or immunotherapy alone. And the tolerance was quite good, even in old patients like in pleural mesothelioma. So it was declared as a new therapeutic option for first line in unresectable pleural mesothelioma with a validation by FDA, but no other countries so far. Another trial pushing for the combination of immunotherapy and chemotherapy as first-line treatment was from the DREAM and DREAM3-R trial from Anna Novak and Professor Ford, Dr. Ford in the USA. Sadly, the trial was stopped too early, I think, clearly to observe a positive effect. So even if they had very nice waterfall plot for the tumor response, objective tumor response, it was not translate for overall survival data, and did not bring any new lessons for a treatment for pleural mesothelioma as first-line treatment. Later, we had also a phase 3 trial with a combination of not only chemotherapy plus anti-VEGF bevacizumab, but also anti-PD-L1 atezolizumab. But this quadruple combination failed to demonstrate a better overall survival compared to chemo plus bevacizumab. And even it was associated with more adverse events, so it did not bring a new proposal for treatment. So looking at the recommendation from ASCO published last year, clearly now you have to distinguish the patient when you choose a treatment according to the epithelioid subtype. If you have patient with non-epithelioid mesothelioma, so biphasic or sarcomatoid, likely, even except if the patient had the bad performance status, the combination of ipilimumab and nivolumab should be likely the first choice of treatment. Alternatively, you can discuss still perhaps chemotherapy, but with pembrolizumab, or eventually with bevacizumab as well, but only in a few countries. If now you have patients with epithelioid mesothelioma, I think the choice is more balanced, even if looking at the 5-year update of the data of CheckMate 743, the first choice will be likely ipilimumab and nivolumab, mostly in many countries, because as emphasized by Professor Anna Novak, many countries do not have access to immunotherapy as salvage treatment. So you may likely choose immunotherapy as first choice and keep chemotherapy as salvage treatment, in particular in many countries, if it's possible, with bevacizumab. If I would go further, I would say that yes, clearly for me, in my choice, we have to distinguish now the patient not only on epithelioid versus non-epithelioid subtype, but in the future, we should take account of other parameters provided by pathologists, like the grade or the subtypes of the subclasses, sorry, of epithelioid subtypes, because they can differ really on the outcome based on these parameters. And for the moment, we don't have access to platinum pemetrexed, and I'm not sure it brings enough benefit in many patients, even if this represents now a choice for many clinicians, for example, in the USA, because they are very used to in lung cancer patients. But I think mostly we have to push for new clinical trials looking to personalized medicine that will be detailed by Professor Dean Fennell after, with biomarker, immunoscore, and other tools. What about the future options? So I already discussed different trials. I did not have time to discuss too much, sorry. The atomic trial could be another option for non-epithelioid patients, but it was not approved so far by FDA or EMA. I won't discuss TTF fields because I think there are not enough proof in mesothelioma. But mostly I would like to move now to more things to discuss in the future in the last minutes. Moreover, in the second or further lines of treatment. There are only a very few positive data from phase 3 trials. Mostly I will talk about the confirmed trial from UK, Professor Dean Fennell and colleagues, who show that we could use nivolumab as salvage treatment after chemotherapy. This was confirmed versus placebo, despite previous negative phase 3 trials, the PROMISE trial, who failed to show any benefit of pembrolizumab versus old chemotherapy like vinorelbine or gemcitabine. But again, be careful because in many countries this is not available, and that's why many people now receive nivo-IP as first line and rather other combination of chemo as salvage treatment. However, when you look at ASCO guidelines, in some patients responding to nivolumab, ipilimumab as first-line treatment, if they had a good benefit of treatment without unacceptable toxicity, there is some option now to retreat patients with immunotherapy, and I did it myself in the practice with few patients, sometimes with success. So that could be something to take account in some patients when they had a long benefit and no contraindication of reintroduction of immunotherapy. Otherwise, you could use pemetrexed again if you had a benefit previously with pemetrexed already or as a salvage treatment and other drugs. Or of course, the main choice would be to recruit patients in clinical trials. So for the next step, I won't go too much in detail because I think Dean will do it better than me later. In particular, all the option of targeted therapy, but there is no phase 3 trial so far for these drugs except bevacizumab with the MAPS trial. What about the immunotherapy? So there are many new immunotherapy. I will focus just on a few ones, and in particular about the checkpoint inhibitors with bispecific tools. So you can help the immune response against tumor and against mesothelioma in different ways when you use these drugs. And that's the rationale of many trials, but the only phase 3 trial so far with bispecific antibodies in pleural mesothelioma is the first-line trial EVOLVE-MESO, who test the combination of first-line standard chemotherapy, platinum pemetrexed, plus a bispecific antibody, anti-PD-1, anti-CTLA-4, called volrustomig, versus standard treatment, so nivo-IP or immunotherapy at the choice of investigator. I don't have time to detail all these other trials, but this is the only phase 3 trial. The other phase 3 trial I could find on the ClinicalGov website was the interesting trial about proton therapy in mesothelioma, the HEAT-MESO. And another one is the peroperative treatment, the atezo-meso from Italy, testing the adjuvant atezolizumab anti-PD-1 versus placebo after pleurectomy decortication. So volrustomig quickly is a bispecific antibody with a double target, CTLA-4 and PD-1. And they recruit now 850 patients for this trial, and all the patients were recruited, and now we are waiting the results, likely not before at least 1 year, because the first endpoint is overall survival in epithelioid population with key secondary endpoint with PFS and overall survival in the full population. There are other trials. For example, in France, we are testing new checkpoint inhibitor, anti-LAG-3 plus anti-PD-1 plus chemotherapy versus chemo plus anti-PD-1 with the LAG-MAPS trial. And we have another trial, the BMAPS trial, targeting anti-VEGF, anti-PD-1. This trial is nearly finished for the recruitment, and we hope it could bring new hope as well. I don't have time to detail the intrapleural immunotherapy, but I think some other speaker may do it later. So testing new cellular therapy like dendritic cell therapy, gene therapy, or even we do some combination, for example, in Lille, associating photodynamic therapy plus challenge or re-challenge with anti-PD-1, PD-L1, and we already treat 18 patients so far. So my take-home message is pleural mesothelioma is a cancer still hard to treat, but now we have really to take care of the different profile of patient for treating this patient with new therapeutic, thanks to ongoing research. Immunotherapy is really a big revolution in pleural mesothelioma, but I think more is coming. but we have really to better select the candidates for each treatment and, of course, for clinical trials with personalized medicine. I would like to ask you to join the effort we try to do with the Predict Meso UK, IMIG, and even EISLC by clicking on the code to join us with IMIG as well as Meso UK. And also, please note on your agenda the next IMIG meeting on August next year in Western Australia. Thank you very much, and thanks to my patient and my colleagues.
Thank you, Professor Shepil. That was a fantastic talk. I'm now going to move on, and it gives me great honor to introduce, I think he's already well known, Professor Dean Fennell is a physician scientist who's focused on advancing stratified therapy and immuno-oncology for patients with mesothelioma. He has designed and led several investigator-initiated trials from phase 1 through phase 3 trials, including some of the landmark trials such as Confirm. He's worked on the MIST series and now most recently on the Select series of clinical trials. His lab currently focuses on novel precision medicine strategies and understanding mesothelioma evolution. He was past president of International Mesothelioma Interest Group, past NCRI Mesothelioma Chair, and has co-authored multiple high-impact publications. And I've had the privilege to be his first clinical research fellow and train under him in mesothelioma. So over to you, Professor Fennell, who will be talking on precision medicine on mesothelioma. So just could I ask for questions to be discussed? We'll have a roundtable of Q&A at the end of this session with all other speakers as well. Thank you.
Thank you very much indeed, Sean. Again, thank you everybody for attending this first global webinar. I'm going to talk about precision medicine, really as an aspiration, one that we're trying to really forge forward with in some of the new clinical trials we're working on. In the short talk, I'll talk about, in part, small molecules. These are tablets which can target potentially mesotheliomas with a particular genetic background, and also a little bit about immunotherapy and how we might be able to target patients more efficiently. The goal of any cancer therapy, of course, is to achieve benefit, response, shrinkage of tumors, and longer survival. But we know that patients differ. They differ fundamentally in their biology, and it's because of that difference between individuals that only a proportion of patients tend to benefit. With chemotherapy, this could be between, say, 25 and 40% of patients having a shrinkage. With immunotherapy, it may be around 40%. That still leaves the majority of patients not necessarily having shrinkage of their tumors. What we would like, of course, is to know how we can identify patients who are likely to benefit and thereby avoid potentially futile treatment and toxicity without benefit. And so what I'm going to describe are approaches now that are getting us a little bit closer to being able to perhaps target mesotheliomas more efficiently. So in the few minutes I have, I'm going to divide my talk into these two topics, targeting genetic differences and precision immunotherapy. So if we look at the biology of mesotheliomas, we've learned a lot over the last few years, thanks to a number of studies allowing us to DNA sequence these tumors. We can see that they have or don't have specific mutations. And these mutations may act as vulnerabilities for certain therapies. That means that, for example, you can see MTAP here. If you have this mutation, this may render the tumor more sensitive to specific treatments, similarly NF2 or BAP1. That's the idea. And so by defining the biology more carefully, we may have a way of being able to selectively target mesotheliomas. So what do we know about mesothelioma? Well, some of the studies that have been done over a number of years have really summarized, this is perhaps one of the larger studies in around 1,000 patients from a Swiss paper, that shows how commonly these mutations occur. And you can see some of these are very common on the left and some of these are very rare on the right. Now, a lot of these can be targeted, as you can see. Actually, these are drug targeting strategies that show promise either in the lab, and some we have clinical data for. And the idea here is that if you have a particular mutation, of course the cancer cell is happy, it can survive and grow, But there is a vulnerability, and that vulnerability, let's call that B if you have the mutation A. If you combine the targeting of this vulnerability, this sort of behavior that the cancer cell has that is required to survive in the presence of the mutation, if you can target that in the presence of the mutation, you get lethality. We call this synthetic lethality, and there's a specific approach that we need to adopt if we want to be able to target these types of mutation in patients with mesothelioma. So I'll give some examples of where we're going, but first mention a clinical trial in which we want to evaluate this concept. So this is called synthetic lethal cancer therapy, synthetic lethality being exactly what I've shown you. And the idea here is to test the hypotheses, to ask the question whether or not identifying a particular genetic background allows us to then target the cancer effectively or efficiently using a specific treatment. So we have these candidate-specific treatment arms or CSTs here. And for one mesothelioma with a particular molecular profile A, we would give drug A, for example. And then similarly for other different types of biology, we would then use alternative drugs. Now, this mirrors to some degree what we've previously done in the MIST trial. What this trial, however, does is really focuses very much more specifically on targeting genetic differences in the cancer. So this is one example of a trial that's currently open in the UK. And this is using a mutation called MTAP, which I showed you a bit earlier. The deletion of MTAP is quite a common event in mesothelioma. It happens around about a third of the time. And when this mutation is present, it creates a certain vulnerability. And that vulnerability is a susceptibility to inhibition of this protein called PRMT5. In other words, if you switch off this protein PRMT5, you can selectively kill cancer cells that have this mutation. Here is an illustration of this in these two graphs. In red, I'll show you this first. This is a tumor in a mouse model, and you can see here that there is regression, shrinkage of the tumor in a cancer with MTAP when treated with a specific drug. And you can see here in cells that there is reduction in the viability. This is the killing of cancer cells that have the deletion of MTAP, have the mutation. And in patients, this was an early phase study that was published, which shows the tumor exhibiting shrinkage here with a PRMT5 inhibitor. And so our hope is actually that in this first phase 2 study in patients with mesothelioma, we'll be able to demonstrate some meaningful activity. And on the basis of that, we would want to then, of course, proceed with a larger study as proof and hopefully to support licensing of this treatment if it's effective. So we're hopefully going to be recruiting this study by the end of the year, and we're actively engaged in that process. What's interesting is that MTAP itself may actually confer sensitivity to current treatments, such as pemetrexed. I won't go into the detail about this metabolically, but there was a lovely paper published recently that showed that tumors that have this particular mutation, as I say, about a third of patients, tend to respond better with regard to pemetrexed. And in our practice, where we've been able to measure the presence of MTAP mutation, we are indeed seeing a pattern here where patients with this particular mutation seem to be doing better with pemetrexed, and in fact may be able to get repeat treatments or so-called re-challenge, explaining something that we've been doing for quite a while, but perhaps not having the molecular information to explain why. Now, in the SELECT trial, there are a few novelties I want to show, one of which is that we'll be doing molecular testing of the tumor, and we'll be able to do this internationally. So we're working with Australia and our pathologists in the UK to be able to see the slide. We can actually see the tissue and the staining of the tissue. And we can score that digitally using remote pathology. And of course, working with our colleagues in Australia gives us something like a 24-hour pipeline, essentially, where we can hopefully get the testing done fast enough that we can get these patients treated quickly, which we have to do because MTAP, of course, is a mutation which makes cancers grow faster and makes them more aggressive. And so speed is everything. Another target that is currently being developed is TEAD. And TEAD is an important driver of mesothelioma. It's one that we believe may be activated and promote properties such as invasion, which can cause pain, of course, and even metastasis. A drug, VT3989, was recently published. This had quite impressive single-agent activity. Of course, not everybody responded, 26%, but the disease control, this is the amount of, proportion of patients that actually had stabilization of their cancer or shrinkage, was 85%, which is very impressive compared to standard of care treatments. There was a hint that using biomarker Merlin or YAP, it's possible to potentially enrich patients who may benefit, in other words, pushing this response rate up in a select few patients. There's another clinical trial. This initial study, phase 1, has been reported in Nature Medicine, is now closed, but there is a trial that's currently open. This is called the TEADS trial. Data was recently presented at ASCO this year in Chicago, 27% response rate, very comparable to the VT3989. Disease control rate, again, comparable. Small number of patients, only 18, but 77% of patients with disease control. So this is a study that's currently open in Finland, France, Spain, Switzerland, UK, including our centre, and in the USA. Moving beyond that, we showed in our previous MISS trial that PARP inhibitors, a class of drug that is useful in breast cancer and ovarian cancer, seem to have some activity, actually causing shrinkages in a minority of patients, but nevertheless suggesting that there was biology there that could be leveraged. And we ran a randomized clinical trial called NERO. We can see here that patients did marginally better, hazard ratio is 0.72 for niraparib. This was a positive study, but the margin of benefit was not substantial. We therefore used a combination of genetics and cellular analysis to try and work out what features were predicting benefit. We identified that the more chaotic the genome was, that is, how many mutations are present and how disordered the DNA was actually an effective predictor. We can see here that those patients with a lot of disorder, we call this weighted channel entropy or WSE high, these patients did much better than those who had a low marker. And for those patients who had a low marker, there was really no difference. So this indicates, again, that through the use of biology, we can identify potential biomarkers that may have value in selecting patients likely to benefit from therapy. I've got one or two slides about immunotherapy. Some patients do incredibly well with this treatment, and there may be a cost in terms of toxicity, but this is an example here. And of course, we want to zone down on those patients who are going to do well, and perhaps, again, offer them personalized therapy. So here in the CONFIRM trial that Arnaud mentioned, there are a subgroup of patients that do exceptionally well. And you can see here, if you have a nice deep shrinkage of the tumor, this is a graph showing reduction in therapy. So the more negative, the more down this is, the deeper the shrinkage. And these patients have no benefit whatsoever, with growth as the very best outcome. And you can see here patients do much better in terms of the duration of stabilization and also how much longer they live. Well, using different techniques, again, DNA sequencing and other methods, we're able to show that there are a subgroup of cells which are essential for benefit from immunotherapy. And these happen to be organized actually into clusters. And you can see those. And in fact, AI, or artificial intelligence, is very good at seeing these and counting them very rapidly. And so one approach, for example, might be to look at the so-called tertiary lymphoid structures in the tumor as a way of predicting patients who are likely to benefit, because it's only if you had these that you really were in this favorable group. Other techniques using the use of gene signatures and so forth may also achieve a similar result. This is one that could be perhaps practically implemented. And working with colleagues based in Cambridge, we've been able to have a new model that allows us to rapidly count these objects and is essentially clinic ready. Other approaches are to target mechanisms, specific mechanisms that might be involved in resistance. Here, in the new upcoming trial called the Impact Meso trial, we're going after something called immunosuppression of T cells via the adenosine pathway. And here, particularly in patients with this MTAP mutation that I've been going on about, this may be a useful strategy. So this is a randomized trial, which we'll be examining. And then finally, the INFORM trial is a study that we are conducting. This is using a new type of drug, actually, called a nanocell. In short, this is a very complex slide, so I apologize, but in short, this is a large structure, and it tends to get trapped in blood vessels, except in the cancer where it can leak out, providing a certain level of specificity for the cancer. On the surface of these nanocells, we also have a targeting molecule, which will adhere to the cancer cell, get taken up into the cancer cell, and then kill the cancer cell by releasing a toxin once it's inside. In parallel with this, there is another adjuvant substance, galactosylceramide or GC, which actually activates natural killer cells. These are the immune cells then that come in and then mop things up. And together, some of the early data with this has shown promise. In fact, it was patient family that actually alerted me to this. And now it's through that contact that we've made with the company that we're actually doing the trial development. So a wonderful example here of patient engagement, this time leading to potential therapy. So in summary, precision medicine for mesothelioma is here. It's arrived. It is entering pivotal trial territory. What I didn't mention is that the first TEAD inhibitor I showed, that phase 1 trial published in Nature Medicine, is leading to a phase 3 trial that was announced last year at the point of presentation of the data. MTAP testing, I think, may become standard in the UK. It's incredibly important for prognostication, but also potentially for predicting drug activity, although we still have yet to see the results of select meso-1. And the next generation immunotherapy, particularly in the first line setting, may be available in late 2026. We've been beaten to it. Obviously, Arno is doing some wonderful work with the LAG and other studies as well. So I think we'll see much more activity in this immunotherapy space, and fingers crossed we'll see patient benefit arising from that. So thanks very much indeed for your attention, and thank you to my colleagues for their support. So I think actually, thank you very much indeed. I've got now Joe Friedberg, I believe.
Yes.
Sean, that's right,
yes.
for me to introduce. So, gosh, it is my pleasure actually to go around the world and now to introduce Joe. Joe, if you just bear with me a second, I read your very interesting bio here. I'm going to just take a minute. I know I'm eating into your time, so I do apologize. But yeah, Joe, we've known for years actually, is a highly respected thoracic surgeon based in the US. And professor of thoracic medicine and surgery at Temple University. So first degree in bioengineering, and spent many years training at Harvard and Brigham and Women's Hospital, very well. He has really pioneered the use of surgery, has multiple patents, has been and is on the board of the International Mesothelioma Interest Group, and served on the Mesothelioma Subcommittee for the International Association for the Study of Lung Cancer. He's also on the MARF Scientific Advisory Board. What I didn't know actually is that you enjoy pottery. Is that what you call it in the UK, maybe?
Okay.
Yeah.
Lathe.
And I need to get some parental advice from you. 7 children is absolutely amazing. So congratulations for that. 3 twins. Joe, it's an absolute pleasure to have you speak, and look forward to hearing your talk. Thank you.
All right. So we're going to go from the most sophisticated treatment to the least sophisticated treatment, basically just cutting it out. And I'll be talking to you about surgery today. Next slide, please. And I have no disclosures except that I guess Tom Cecil broke the ice this morning by showing some surgery slides, but I'm told this is a mixed audience, so if you are squeamish, there are some graphic slides in here, and you may want to sit down for some of those. So advance, please. Keep going. Two more clicks. So what I'll tell you about is the accepted rules for surgery for pleural mesothelioma. What's the current status of surgery as a treatment for pleural mesothelioma, how some of us do this surgery, and then what the future holds. Next slide, please. So the accepted standard of care role for mesothelioma, for pleural mesothelioma, is not surgery, but it is standard of care for both diagnosis and for palliation. If you look in the top left corner, you can see that's basically a 1 centimeter incision. You can make a hole, introduce a video camera, and do some biopsies. The top middle panel shows a biopsy of extremely early stage mesothelioma. You're going to take a piece of that. I like this because if you look toward the right at about 3 o'clock, you see that yellowish thing. That's actually an asbestos plaque. And so when you see that on a CAT scan or X-ray, that's what they look like in real life. You can combine these. Patients often present with pleural effusions, so this is a chance to palliate the effusion. If the lung expands fully, you can introduce some talc at the same time, which is what you see in the bottom left. Looks like a snow scene there. That's you can puff in some talc. The lung will expand and stick to the chest wall and prevent the effusion from recurring. Or more commonly, we'll end up putting in these tunneled catheters, which you can see the Pleurix catheter in the top right and the way it goes in on the left. The patient go home with a bottle and evacuate that. So palliating these effusions are very important. These are the standard roles. It is important, you just heard several talks that there's different treatments for epithelioid versus mixed or versus biphasic or sarcomatoid subtypes. And the important thing to know is that the effusions only contain the epithelioid subtype, only the epithelioid element shed into the fluid. So you can have a biphasic cancer, and unless you do a biopsy, you won't know that. So surgical biopsy, I think, should be considered standard of care for mesothelioma at this point. This concludes the standard of care portion of surgery for this talk. Can I next slide, please? So what about treatment? Next slide. The standard of care treatment for mesothelioma is systemic therapy. That's the end of the discussion. And you heard some things coming down the road, but as of now, basically, the combination chemotherapy established in 2003, and then the addition of immunotherapy in 2021, that's standard of care. After that, the addition of anything else would technically, including surgery, would be technically considered investigational. Next slide. Well, what about surgery as a treatment? So let's move on. I think it's important, if you click 2 more times, please, to think about, and I explain this to the patients, there's different roles for surgery in the field of medicine. Someone comes in with an appendicitis, the top left panel, that's a short conversation. You can have surgery or you can die of appendicitis. There's no other treatment for this. Then you can have something like the middle panel, which is, say, an early stage lung cancer. You can take out the cancer completely encased with normal tissue. You're not violating the plane of the cancer. If it has not spread to this point, then you can cure someone with surgery. And then the bottom left panel shows sort of a netter cartoon or drawing of a pleural mesothelioma. And this cancer coats every surface. And so it is not possible to achieve what we call a microscopically complete or R0 resection like you could for a lung cancer. The best you can do is remove all the detectable cancer, understanding there's going to be invisible or microscopic disease still remaining. So you cannot cure anyone with surgery for mesothelioma. And that's why it is not considered standard of care. There's no chance of cure. You're trying to basically remove the bulk disease, and that's the best we can offer. Next slide, please. And the analogy I use for the patients is, as opposed to the lung cancer where you're taking the whole thing out, it's more like you're trying to scrape the paint off of a board or something. You can take it all off. You can look like you got it all clean, but if you go down there with a microscope, you're going to see some residual paint chips. That's what we have. And so what we do know, and I think this is pretty much universally agreed upon by surgeons, is that if you're going to do surgery, you need to combine it with other treatments. This is a slide Val Rusch gave me years ago, basically showing the survival for surgery alone versus surgery with any other treatment. And the blue line above is the other treatments combined with surgery for mesothelioma. So if you're going to do surgery for this cancer, you need to add something else. And in my case, I will not operate on someone unless they agree to have systemic therapy. Next slide, please. But that's where the agreement ends. These are the things you can combine with surgery, that have and are combined with surgery. You can have radiation, chemotherapy, immunotherapy. You can do it before surgery. You can do it after surgery. You can do it during surgery. And then we have the chest open. We have all these other things that you can do intraoperatively: heated chemotherapy, heated iodine, photodynamic therapy, ablative therapies. There's a number of things. And then it's a complete free for all. There's absolutely no agreement on the sequence, the combinations. Everyone is sort of doing something a little different, unfortunately. But that's the way it is for mesothelioma and surgery right now. Next slide, please. So what needs to happen for a patient to have surgery? Well, they have to be a safe candidate for a big operation. And you heard, like in Tom Cecil's talk, it is a big operation. It has to make sense from an oncologic perspective. We'll get to that. And basically, the patient must give informed consent, which is going to include the fact, at least with me, that this is not standard of care. The chance of curing you is essentially zero, but we're trying to extend your life beyond what we would anticipate with just the systemic therapy alone, and they must receive the systemic therapy as well. Next slide. So what do we actually know? Usually, the staging system for solid tumors and surgery, that's your North Star. If you have a lung cancer in stage 1, surgery is standard of care. Same with colon, same with breast, same with pancreas. We don't really have that. Our staging system right now is not a good guidance. And I would submit to you that in these two patients below, the patient on the left could actually be a more advanced stage than the patient on the right. And I could also tell you that based on the subtype of the disease, which is not part of the current staging system, the patient on the right with the larger tumor could actually do better than the patient on the left if that was a pure sarcomatoid. Next slide. So these are the sort of things, and unfortunately, it's still part art, not just science, like it is with other solid tumors, deciding who should benefit from surgery, what combination treatments they should have with surgery, etc. So the epithelioid subtype, the lower tumor volume, those are probably the biggest ones. They're not part of the current staging system. No negative, lack of pain, platelet count, female gender for whatever reason. These things all go into sort of the decision making as to whether or not to offer a patient surgery. Next slide. If you're going to do surgery, there's basically two options. Next slide. You can save the lung or you can take the lung. Next slide. Initially, we all basically took the lung. This is that operation. This is where I was trained, and this was when I trained originally. Everyone, I would call this a radical extrapleural pneumonectomy. You basically take out the entire lung, the diaphragm, the pericardium as one unit. That's what I'm holding on the right side there. The lung and everything's inside there. You can't see it. The bottom left panel shows actually the pericardium from the inside. The bottom middle shows the diaphragm muscle, and then you can see the reconstruction. You have to reconstruct the pericardium and the diaphragm, and that's what you're looking at there as reflected in the cartoon above. That's the way that we would do an extrapleural pneumonectomy. You can modify that some, but this would be the classic operation. Next slide. And that, by the way, is the only way, that would be the only way to completely standardize is to do this completely radical operation on every patient, which I don't think makes sense. Then there's lung sparing surgery, which I think is the dominant procedure that's performed throughout the world, but people still do extrapleurals now. The operation, I can just take this through. It starts off the same way. If you look at the cartoon with the hand there on the top left, you basically start off by yes, thank you. You start off by separating the cancer from the bony hemithorax, from the chest wall. You get into that extrapleural plane and take that off of the chest wall. And then if you click on the one beneath that, this is the phrenic nerve. Whether or not it's worth preserving that, I don't know. You can see the heart beating underneath that. That's the pericardium, which has already been removed. I'm preserving the phrenic nerve. Then basically bottom left. Yep, click that one, please. Uh, Next thing is to separate the diaphragm. That's the diaphragmatic musculature there. The cancer is on the top. And the goal here, and sometimes it's invading the muscle, so I'll split the muscle, try and preserve it. This is variable from patient to patient, determined by the cancer. But basically, what we've done now is we've mobilized the cancer off the chest wall, the diaphragm, the mediastinum, it's off the pericardium, and now it's just tethered to the lung. And so what I came up with is I put that lung under positive pressure. The other lung is being ventilated normally. And then we incise the cancer. So if you click the bottom middle there, uh, what we'll do is we'll incise the cancer. And what you're looking at, I'm holding up that peel of cancer there. All that white thick stuff is the cancer. And we'll divide that down and basically take the entire cancer, which was mobilized off of the parietal pleural surface, along with the visceral pleural surface, which is like this cellophane that wraps the lung, which looks like a sponge without it, and take that whole thing off. Top right. Sometimes it's too invasive and it won't separate surgically, so I'll actually use the electric cautery to separate the lung. Same principle though, we keep working around the whole thing. And then the next one down. Sometimes this is what basically normal pleural looks like, but if you send that to the pathologist, that's going to have cancer in it, even though you can see through it. But that's what normal visceral pleural, the surface around the lung, looks like. Same thing, we'll divide all the way around. And then what I've changed to over the past several years, and we presented this at World Lung a couple of years ago, and does not seem to affect survival, but allows you to limit the air leaks. You can imagine if the lung is like a sponge wrapped in cellophane, you take that cellophane off, the air leaks out. That's the most predictable thing that you have to deal with postoperatively and responsible for the prolonged length of hospitalization for a couple of weeks usually. If you do this, and so if you click the bottom one, this is actually sort of a bipolar, passes current between it and actually passes water between it. I'll cauterize the surface of the lung while saving the visceral pleura so it doesn't leak air afterwards. And that seems to be I'm trending toward that, trying to make this operation a little less of an ordeal for the patients. Next slide, please.
Joe, if I may, just to let you know, we just have a couple of minutes left, if that's all right.
Okay, so I'll just fly through these then. So these are some intraoperative treatments you can do. Next slide. This is what the specimens look like. You can see the cancer is out there. The lung has been denuded. Next slide, please. These specimens, I don't know if saving the lung is always the right thing to do, but you can have this cancer is 2 liters in volume. You can do it and save the lung. Next slide. Next slide, please. So let's talk about the Mars 2 trial. Next slide, because Liz put in the comments that you can't really get surgery for pleural mesothelioma in the UK, and it's because of this. This was the Mars 2 trial. It was a randomized trial trying to determine whether surgery plus chemotherapy is better than chemotherapy alone. And the short version is that at about 2 years, the surgery group had an overall survival of 19 months, and the chemo alone had a survival of about 2 years. So it was considered a negative trial for surgery. And, basically in the UK and other places, I think this is taken as the indication that you should not do surgery for these patients. It doesn't help. So why would you do it? Next slide. This is next slide, please. This is just a series of studies, and if you look at this, these are just a number of studies that I pulled, surgery-based treatments, all in green, just a number of them throughout the world, Far East, US, UK. And you can see the Mars 2 chemo group, the top one in the red, and then the bottom one in the red. So is this because you did surgery in all these patients? Are they doing something different? I don't know, but that's why those of us are still doing it despite Mars 2, and why we believe that surgery is, and it's a different treatment everywhere, like I talked about. Next slide, please. Is this because is surgery helping? I don't know. It seems unlikely that you would have those outcomes with just a systemic therapy, but it is possible, and I wouldn't tell you it's not. Next slide, please. Keep going. Next one. Let's go all the way down. It's such a hard thing to study because it's such a small number of patients have mesothelioma, and uh, only a small percentage of those undergo surgery. So it's a hard thing to do. The staging system does not serve as a common denominator currently, so we can't really compare and pool these things. The nomenclature is not standardized, the surgery is not standardized. Even the same surgeon trying to do the same operation, the cancer can dictate that you do a different operation. So right now we're stuck with kind of comparing apples and oranges. Next slide, please. And you can go on to the next slide. I'd say basically the answer to this is going to be what you've already heard several times today, which is that we need to really work as a group, combine these numbers, and do this internationally, collaborative trials. IMIG 2025, one of the things that came out of it is a collaborative trial where we're basically trying to form an international database. This could serve as the foundation to move forward and do some of these trials that can really answer the questions about who are the patients that should have surgery, or if anyone should even have surgery, and then try and standardize this as much as possible. And next slide, please. So again, just thank you to all the people who have helped out, especially Melissa Culligan throughout the years. Just a tremendous amount of work doing all these trials. So thank you.
Thank you very much indeed, Joe. Just for everybody, we're going to take the questions at the end. We have a virtual round table, if that's okay, Joe, if you could stick around, that'd be wonderful. Thank you very much indeed.
Thank you. Gives me great pleasure now to introduce our next speaker, Dr. Crispin Hiley. He is an associate professor of radiation oncology at UCL and an honorary consultant, clinical oncologist at the UCLH Hospital in UK. He specializes in non-surgical treatment of lung cancer and mesothelioma, including systemic therapy, stereotactic radiotherapy, and proton beam therapy, and is currently leading as the chief investigator for the HIT Meso clinical trial, which is this national study evaluating proton therapies for pleural mesothelioma. Over to you, Crispin.
Thanks very much. Hopefully you can hear me okay. Very, very grateful to the organising committee to put me in a roster of such impressive speakers. So thank you very much. So I'm a clinical oncologist in the UK, which means I do systemic therapy and radiotherapy, and also I do some genomics and science. I'm not really sure what I am, but it puts me in a nice position to be able to sort of think about managing mesothelioma from all perspectives. And I've been asked to talk about radiotherapy, and so I will do that and try and see if I can get us back on time a little bit. So next slide, please. So this slide is really just to say that, radiotherapy is, like surgery, like systemic therapy, has really evolved over the last, 10, 15, 20 years, at every step of the pathway. It's a very complicated process getting a patient from the start of radiotherapy planning to the end of treatment. And that's really helped by advances in imaging that we use to help get radiotherapy planned, all the dose calculation algorithms that we use to make sure that the dose we deliver is the dose we planned, all the things that help us make sure that patients are in the right position every day, which sounds trivial, but actually those things weren't available 10 years ago even for a lot of radiotherapy trials. And then the different ways we can deliver that, which I'll talk about, sort of stereotactic radiotherapy, protons, MR-Linac, all these different things. So it's really evolved a lot over the last 20 years. Next slide, please. So I guess this is just a little bit of context. So radiotherapy, mesothelioma has historically, to some people, been considered a radiation-resistant cancer. And this is just a figure from a paper published, 10 years ago now. Really nice study where they got different cancer cell lines, studied them in vitro, so in a plastic dish, very artificial. And irradiated them at the same dose, and they looked at how many cells survived. And so on the x-axis is different cancer types, each notch, and then each dot above that is a different sort of cell line. So you might have lots of different liver cell line cancer cell lines, lots of different lung cancer cell lines, and more sensitive cell lines are lower down on the y-axis, more resistant cell lines are higher up, and the red dashed line is the sort of median sensitivity for that particular tumor type, that histology. And as you can see, mesothelioma is missing, but actually it was done and it was in the supplementary. And if you just had the next slide, please. You'll see here on the right, those are the mesothelioma cell lines. There's less of them, but they're there. And if you sort of look at the median level of sensitivity of mesothelioma cell lines, at least in plastic, in a dish, it's actually very similar to on average to all the other cancer types. So it's not necessarily intrinsically more radiation resistant. The issue has always been about the volume of disease you're trying to target, which we've heard about during Fiber's great surgical talk. Next slide, please. So I'm just going to talk to you about what evidence there is. So I'll talk a bit about palliative radiotherapy, stereotactic radiotherapy, and then I'll come on to hemithoracic radiotherapy at the end. Next slide, please. So these are the ASCO guidelines. I'll structure the talk around that. So again, patients with symptomatic disease, there's a role for radiotherapy as an effective modality of palliation to help with pain. And there's different ways you can deliver that, and there's sort of different doses you can use to achieve that aim. And that's, sort of empirical and clinician's best judgment of what dose and fractionation, how many treatments to use. Next slide, please. So again, the evidence for this is based on the system study, which is a very small trial of 40 patients published, over 10 years ago now. The patients got very simple 20 grain 5 fraction, and the endpoint was clinically meaningful pain improvement at 5 weeks post radiotherapy, and half of patients got that. So, worth bearing that in mind, that not every patient will get pain control with radiotherapy, but it definitely works for many patients, and it should always be given in conjunction with good, palliative care and analgesia. And then we went on and do the Systems 2 trial, which was 18 centres across the UK looking at sort of dose escalation, so 36 grays, so giving a bit more radiotherapy. Again, same endpoint, completed recruitment in 2023. No significant benefit actually giving more dose in terms of pain control. But there was a suggestion, we still wait for the final publication, but there was a suggestion of improved survival as a secondary endpoint for patients with a higher dose. So again, 20 grain 5 fractions, 36 in 6 fractions, so very similar in many respects. So if patients are well enough, and I think it's the right thing, I will give them 6 fractions sometimes. Next slide, please. And then what about patients with localized asymptomatic recurrence? So, okay, here it just says radiotherapy can be offered. Dose and fractionation, and also modality to be determined by the radiation oncologist. So it's quite vague, but that's, I think, the right thing because there's limited evidence. Next slide. But what we do know is that cancers all don't behave in the same manner, and I do a lot of research looking at sort of tumor heterogeneity. And this is a cartoon from a paper about RECIST measurements, and this is not modified, mesothelioma RECIST, but this is in general. This sort of trial measurement of tumor lesions doesn't take into account the fact that some parts of a tumor might respond to treatment and other parts of the tumor might not respond. And how do you manage that? We know clinically that these discordant responses happen. And we even see that in mesothelioma. Some patients may have great responses to treatment, and then at some point an area will start to grow out. And how do we manage that? And that's kind of called sort of limited progression or oligoprogression. And that is genuinely a clinical feature of mesothelioma progression in some patients. It's sort of limited areas of progression. Next slide, please. And one way of managing that is with something called stereotactic radiotherapy. So this is more focused radiotherapy given to a higher dose to a smaller area. And again, all very retrospective data, but in these sort of select patients where we think it's appropriate, good sort of lesion control, good 1 year, the chance of controlling that spot of cancer with stereotactic radiotherapy is very high, anywhere between 75 100%. Again, relatively small studies, all retrospective, but certainly a useful treatment. And you can see on the right, this is one of the more recent publications, the OMAR retrospective study. You can sort of see here that it's useful, the top left graph, it's useful in some patients in delaying the time for the next systemic treatment, which is a very important patient-centered outcome measure, I think. It's very good at local control. You can see that on the top right. But you can see that patients at the bottom right, progress at a distant site, usually, or somewhere else in the thorax. And as a consequence, overall survival is improved, but not to the level that any of us would like. But it's a useful treatment for some patients. But the same in many cancer types, selecting the patient that would benefit from these sort of targeted treatment approaches, whether it's stereotactic radiotherapy, thermal ablation, or even surgery potentially, I think is always the challenge. Next slide, please. And this is just an example of a treatment. You can see here a patient with sort of disease in the chest wall, and getting 50 gray in 5 fractions, and then on the right, so the following year that lesion's really shrunken down, and so it is a very useful and a very well tolerated and a very safe treatment. Next slide, please. So, okay, I think, oligoprogression is likely to be increasingly common in some patients, particularly after immune checkpoint inhibitors. We don't have all the data to really understand how common that is. And I think the benefit of this sort of local treatment will really be driven by the pace and the biology of an individual patient's mesothelioma. And there is no randomized data, and it's always challenging because, there's sort of a lack of equipoise to some extent in a lot of these studies, but we do need to think about how we can do those trials. Next slide, please. So the last thing I'll talk about is hemithoracic radiotherapy. So this is, as you've seen from our surgical talk, great surgical talk, is the pleural lining is a very large area. This to trying to treat this with radiotherapy is probably the most difficult and technically demanding way of giving radiotherapy to any patient. It's much more difficult, much bigger than a head and neck cancer, lung cancer. This is a much larger area, and we're trying to give a high radiation dose, 50 gray or more, and particularly when we've got sort of organs at risk, OARs in close proximity, the opposite lung, the heart, the ipsilateral lung. And next slide, please. And people have been trying to do this for many years. It was difficult to deliver with old-fashioned 3D conformal radiotherapy. More recently, the Italian group did a trial with tomotherapy with, again, this is more modern IMRT, slightly different machine that's quite good for helical structures like the pleural cavity. And again, quite encouraging, enable survival benefit, a much lower a local regional recurrence rate at 1 year. But again, there are some toxicity issues, so grade 5 events, lots of grade 2 events. And so again, a difficult treatment to deliver with conventional radiotherapy. Next slide, please. So what about protons? So protons are an entirely different particle. Much bigger infrastructure requirement. You need a whole building. It's available in specialist centres in big cities, in certain countries. Not everywhere has it. But it has some dosimetric benefits that are useful in terms of being able to spare the opposite lung and the heart. And those are the two organs that were shown to be associated with side effects from this sort of hemithoracic treatment historically. Next slide, please. And we've done planning studies like others, showing that on the left with the proton treatment there at 2 different levels in the body compared to the standard radiotherapy photon treatment on the right there in these images, that we really spare this sort of low dose splashing across to the opposite side into the heart. And we can see that in the box and whiskers plots. We reduce, with the PBT, the protons, we reduce the dose to the heart and the opposite lung with compared to photons to VMAT. Next slide, please. And so we decided to initiate a study. Now, people have published outcomes with proton beam radiotherapy for mesothelioma. That's not particularly novel in that respect. But I think in order to sort of position its use for patients with mesothelioma, we really need to think about doing a randomized study, because it's all well and good publishing retrospective outcomes for patients who did well, and maybe they would have done well without radiotherapy. It's important to do a randomized study to really determine the benefit. And for lots of different reasons, we felt it was appropriate to do this sort of upfront for patients who didn't necessarily need to start systemic treatment straight away. Next slide, please. So the study is called HIT-MESO, funded NASA and Lung UK, open at 20 sites across the UK, 2 proton centres, Manchester and London. And the aim is to assess if radical hemithoracic radiotherapy with protons improves progressive-free survival and overall survival. Those are dual primary endpoints to see and then also to see if it maintains quality of life and whether it's cost-effective. Next slide, please. And this is the study schema. So, eligibility obviously has to be confined to 1 hemithorax, good performance status, adequate lung function. So this is really for patients who are treatment naive, and also appropriate for a period of surveillance, which is recognised as an appropriate option in the 2018 and the 2025 guidelines. And you have to remember that in the Ipi-Nivo trials, only 10% of patients had stage 1 or stage 2 disease. So we don't have a huge amount of evidence for Ipi-Nivo in early stage disease either. And so this is where we position the study. Patients are randomized 1-to-1 to a period of initial surveillance, and then starting standard treatment, whatever that might be, in the at clinical or radiological progression, whereas in the experimental arm, they get 50 Gray and 25 fractions to their hemithorax as a CTV, and a boost to 60 Gray for visible tumour. And again, it's quite a big ask for patients. They have to go and live in London or Manchester for 5 weeks. And so it's a not insignificant commitment for patients when they're randomized to protons. Next slide, please. So we're about a third of the way through recruitment, and I just wanted to show you an example of some patients we treated. And of course, I'm going to cherry pick the most dramatic examples, but this is one I've shown to a few people. This is a patient who had, quite bulky disease. Certainly from my perspective, I wasn't quite sure if we'd get them on or through treatment. You can see the sort of colourful lines on the right is where we sort of draw the CTV in orange and the gross tumour in red, and treating those to 2 different dose levels. Next slide, please. And this is the proton beam radiotherapy plan. So this is the sort of high dose region. If I was to show you the low dose region, you'd see that we spare the opposite lung, we spare the heart, and we get some sparing of the ipsilateral lung, but that's challenging. Next slide, please. And the picture on the left is the sort of what we call the day 0 verification CT, which is the sort of what the cancer looked like on day 0 at the start of treatment. And on the right is the sort of the cone beam CT that we took on the last day of treatment 5 weeks later. And you can see a really dramatic shrinkage of that cancer at that all the way throughout the hemithorax. Actually, just that's a representative slice. But so what it shows is that radiotherapy absolutely shrinks and gets rid of mesothelioma locally. The question is, does that result in an overall survival benefit? Does that keep patients alive and well for longer? And I don't know the answer to that. Next slide, please. So look, protons is a great treatment potentially, but it's not without side effects. Patients get some fatigue, and they also get some ipsilateral fibrosis later on. But certainly the trial will hopefully answer whether it's a useful treatment at that stage of patients' treatment. And certainly mesothelioma is a radiation-sensitive cancer. SABR is a potentially useful treatment for patients with isolated progression. And I look forward to completing the trial and coming back to you and talking to you about the results at some point. Next slide, please. And those are my acknowledgements. I think I stuck to 15 minutes, but didn't get us back on schedule. Sorry about that.
Wonderful, wonderful. Thank you very much indeed, Crispin. Our last speaker of this webinar is Marjorie Zadra. And Marjorie, I'd like to thank you for attending. I'll be very brief, actually. So Marjorie is past chair of the board of directors of the Mesothelioma Applied Research Foundation. She's also section chief, hematology and medical oncology, and director at the WMC Health Center, Cancer Center, and has worked and studied in New York. She's a former prize winner, Pioneer Award from MARF in 2024, had many grants, highly respected medical oncologist. She's going to give a personal perspective on the future of mesothelioma. Thank you, Marjorie.
Thanks, Dean. Can you guys see my slide?
Yes, clearly, thank you.
Okay. So I wanted to thank everyone for inviting me to be here today. When I was asked to speak about the future of mesothelioma, in thinking about preparing this talk, I realized I didn't want to give you guys another traditional scientific review. I think we've heard from lots of experts today. And I could spend time sort of recapitulating what they've already covered so well, telling you about emerging drugs and new studies, promising clinical trials, and those things are really important. But I do want to offer you today my personal perspective. So for the past 17 years, I've cared for patients with mesothelioma, conducted research in the field, learned from families, and watched the treatment landscape evolve. And over that time, my thinking has also changed. When I started, I thought the future of treatment would be better chemo, better surgery, better radiation, better immunotherapy. And we've made real progress in all of those areas. But I think that the future is bigger than treatment alone. And it's really at the heart of that, it's about getting ahead of the disease, finding risk earlier, detecting disease earlier, and one day preventing advanced mesothelioma from developing in the first place. That's the future I really want to talk about today. Sorry, split screens. I'm trying to figure out where to look. My career has unfolded alongside multiple major milestones in mesothelioma, and we've talked about those in a lot of detail today. So when I started, pemetrexed had just become a standard treatment. Then came major changes in the transition from pneumonectomies to lung-sparing surgeries, checkpoint inhibitors, precision medicine, and now emerging targeted therapies and cell therapies. And these are real advances. Patients today have many more options, and we think about treatment much more thoughtfully than we did when I started. But my connection to cancer began long before my medical career. So my grandfather was a firefighter, and over his lifetime, he developed multiple cancers related to occupational exposures. Certainly as a child, I didn't understand carcinogenesis, latency, or environmental risk. What I understood was something much simpler. Someone who had spent his life helping others became vulnerable because of the work he did, and that stayed with me. I think it shaped how I think about illness, risk, and prevention. And I think it's one of the reasons I became an oncologist. Years later, I found myself caring for patients with mesothelioma, another disease deeply connected to occupational exposure and environmental exposure. And I think that that's one reason this disease has always felt so personal to me. When I think about the last 20 years in meso, I think about building better fire trucks. So you'll indulge me in my analogy, but mesothelioma is the fire. The fire trucks are our treatment: chemotherapy, surgery, radiation, immunotherapy. And for decades, our field has focused on making those tools better, and we should, because better treatments matter. They save lives, they extend time, they create options, and they give families hope. Much of my career has been devoted to that work, and I remain deeply committed to it. I want to be very clear, this is not a talk about abandoning advances in focus and effort in the development of those treatments. And so here you can see from the NCCN guidelines that drive a lot of reimbursement treatment decisions in the United States, there's a plethora of choices. And we've made tremendous progress in this, and it deserves recognition. We didn't have all of these choices when I started. We have more clinical trials now. We have a deeper understanding of the disease, and our community has pushed that field forward despite all of the challenges, and that matters. But I also want to force us to ask a harder question. Why are we still meeting so many patients for the first time when the disease is already so advanced? So innovation's accelerating, and as anticipated, these are pictures from trials that folks had already presented this morning, afternoon, evening. Immunotherapy has changed the landscape. We have new combinations of treatments being studied, novel immune approaches, targeted therapies, cellular therapies are moving into clinical trials. And not every idea will work. Science never moves in a straight line, but there has never been a time when more talent, more resources, and more scientific effort has been focused on mesothelioma. And this work is far from finished, but there's a reason for hope. And we also talked about this study with Dr. Friedberg. We're getting smarter about how we use the treatments we already have. Modern oncology isn't only about finding new therapies. It's about matching the right treatment to the right patient at the right time. So who benefits from surgery? Who benefits from immunotherapy? When should treatments be combined or avoided? That's where the field is heading. Not just more treatment, but smarter treatment and more individualized treatment. That's a sign of our field maturing. When I started, much of what we've talked about today would have seemed unrealistic. And here you can see a snapshot of many different drugs, trials that have gone on or ongoing or in development of all of the things we now understand about biology and are being investigated around the world. We know that meso remains a difficult disease, and no one in this room needs to have me tell them that. But all of this gives me hope on the progress we're making. And it's not any one drug or any one study, but it's the momentum. It's the momentum of this community and of the science. The tools are better, the research community is larger, and the energy is palpable. But I think my optimism comes about something even bigger. And this is back to the fire analogy and something my grandfather would have understood immediately. If a firefighter arrives after a wildfire has spread across hundreds of acres, the job becomes much harder. You can still help, you can still save lives, but you're responding to a crisis already in motion. Instead, imagine finding the first plume of smoke before the fire spreads, before the damage becomes extensive. Everything changes. The outcome changes. The greatest victory may not be in putting out the fire. It may be finding the smoke before the fire spreads. So as long as I've been doing this, we've asked a central question. How do we treat mesothelioma better? And that is still an essential question and a place where we're making a lot of progress. Patients need better treatments today. But I think that question's incomplete. And the question I want to challenge us to ask is, how do we prevent advanced mesothelioma from developing? How do we identify people at highest risk? How do we identify the earliest signs of disease and intervene before advanced disease develops? It's a different way of thinking. It's not just treatment, it's prevention, it's early detection, and it's changing the trajectory of the disease before patients become sick from it. I think we can take a lesson and an example from cardiology. So decades ago, much of cardiology focused on treating heart attacks after they happened with bed rest and aspirin, right? Patients developed a symptom, the damage was already underway, and the system responded. But today, cardiology intercepts disease much earlier. There's cholesterol control, blood pressure management, smoking cessation, risk assessment, screening, promotion of healthy lifestyle, and early interventions. And the biggest gains, perhaps, didn't only come because we got better at intervening as a heart attack is happening and treating it, but we became better because of all the heart attacks we've been able to present. It changed the point at which medicine entered the story. It moved earlier. And I believe meso is approaching a similar moment. The next revolution may come from preventing advanced disease and not just treating it more effectively. So that's the central idea. I want to highlight a few ongoing areas of research related to that. But the bottom takeaway point is to find the risk, read the signal, and through that change the future. So how do we do that? Well, I think we're at an interesting moment in science and medicine where emerging technologies have really set us up and empowered us to develop the tools that we need, many of which are already emerging. Each of these tools may help us see something earlier than we can today, but the answer, as you can see here from what a mock-up of what interception might look like for mesothelioma, is it's no single time point, it's no single tool, there's no one magic test. But using all of these tools in a thoughtful, intentional, coordinated way to identify risk at the earliest stages, and hopefully, as we've heard about today, eliminate potential sources of that risk, detect change, right, before the disease has started, and then early detection to be able to act sooner. And that gives us a huge runway of time in which there must be things that we can do to shift the pathogenesis, the development of this malignancy. So here's my sort of 3 points. Find the risk, be smart enough to read that signal, and change the future. The first step is finding people at highest risk. So we talked a little bit about some of those inherited syndromes and families, and I saw some things come up in the chat about this. Not everyone exposed to asbestos develops mesothelioma. So we know that risk is not evenly distributed. Exposure matters, but biology matters too. Family history and inherited susceptibility matter, and other things we haven't yet figured out may matter. So we need to understand who needs intensive early monitoring. And that's how prevention and surveillance become practical and rational. And that's what makes intervention possible. Once we identify those people at higher risk, we need ways to find the disease earlier. And those tools need to be practical. And they need to be repeatable over time. So I'm thinking about fluid analyses, blood tests, exhaled breath studies, all of which are ongoing. And the goal is not simply to do more testing, but to learn whether we can find the smoke before that fire spreads. Artificial intelligence is here, and it may actually help us, not because that AI replaces physicians, but because we have a tremendous amount of information. And if we can pool that and use AI to identify patterns that us as simple humans haven't been able to recognize, we're going to come out with some powerful observations. And it's going to help us connect signals that may be difficult when we look at each piece in isolation. And as others have said today, talking about putting all the different pieces together. And it's not technology just for the sake of technology, but it's making more of the data we all already have. And I think the same is true of imaging. We already get scans that contain a tremendous amount of information, but there may be patterns in those images that are too subtle for the human eye to recognize in routine care. An advanced image analysis with AI tools is going to help us learn more from the scans we're already performing. And again, it's not more complexity, but it's earlier detection to read the signal sooner. An interception won't be built on a single test done once. It will require following people over time and looking for changes, looking for patterns, understanding which signals matter and which don't. And in mesothelioma, as you know, time has often worked against patients. But I think in this future, where we're intervening medically earlier before symptoms emerge, we can use time differently. We can use that long delay between exposure and diagnosis as a window of opportunity, a period during which we can detect change and intervene sooner. I think the encouraging thing is that as I showed little snapshots from some of the recent research in these areas, many of the pieces already exist. The science and technology is advancing, and I think to the great, effort of the group that convened this forum, international collaboration continues to grow under the auspices of this meeting and the other organizations represented here today. Patients and their families and advocates have helped drive this field forward in ways we can't overstate. And what we need now is to integrate all of this expertise and knowledge and data sitting in different silos. And that's why we heard about some of the work that Dr. Blythe is doing. When we bring all of those pieces together, I think that we transform this from a science challenge to a systems challenge and how we integrate all of that information that we already have collected. And I think it's achievable. And I think if we do it and we do it right and quickly and thoughtfully, we can fundamentally transform the landscape of this disease, how people present, when they present, and whether we can transform that chronic inflammatory pathway to something that never becomes a malignancy. So back to where we started. When I started, I thought the future would be better treatment, better chemo, better surgery, better radiation, and better immunotherapy. And as we've heard today, we have made progress in all of those areas. And we've also heard about novel and emerging therapies, targets, and approaches. And that meets the needs of the patients we have today and the treatments they need today and tomorrow in the immediate future. But I believe the greatest advance in the next generation is going to be our ability to move earlier, to identify risk and to detect disease sooner, and to change the trajectory, of disease before patients even become sick from it. For the last 20 years, we worked hard to build better fire trucks, and we should keep building them. But the future is finding the smoke. And back to where we sort of started, I think about my grandfather who spent a career running towards fires. And the future I'm trying to build is one where fewer families ever have to face the devastation of one of those big fires. So thanks for indulging me this morning in that perspective. Thanks.
Marjorie, thank you very much. That was outstanding. Can you stick with us for a few moments? We were due to finish about now, but I think it's right that each of you had time. I'm sorry, Joe, for the time pressure, but it was great to hear everything you had to say. We have a panel. It was supposed to end so about now, 15 minutes. Let's go for 5 or 10 minutes. People want to stay on. We're going to have a quick chat. Anybody who wants to ask any questions, please fire them into the chat to everybody. Can pick them up here, and we'll kick off. Marjorie, I just want to ask, as you were the last speaker, actually. I mean, I totally agree with everything you've said, and it's a very interesting reflection of what we do on a day-to-day job, isn't it? With the active anti-cancer therapies that we work with. Thinking about early detection and screening, I'm thinking about numbers and the types of numbers you might need to develop enough power to predict. Are you thinking about at-risk type populations where you kind of enrich, in which case is that an opportunity for international study, or the sort of the Grail type, sort of big, multi-cancer, pan-cancer type early detections?
Yeah, so, I guess I think the most power will come from looking at exposed individuals and following and understanding who develops disease and who doesn't, and understanding the evolution of the different samples we can track in the background of their underlying, perhaps germline risk profile. And I think the combination of those two things, but definitely enriching for people at higher risk.
So we and others, and Kevin obviously has a huge undertaking with the Predict Meso, collecting a lot of germline data. There's a lot of talk in IMIG, of course, about collaboration. Is that something that could be discussed more formally, do you think, in Perth? Yeah, okay, that's fantastic. Good. Any general questions from anybody, actually, at all at the moment?
I'm just going to ask Joe a question, if that's okay. Joe, just want to check. You said you carry out surgery on those patients, but they should have had some form of systemic therapy. What's your take on this? Do you think they should be going upfront with neoadjuvant, or should we be applying a perioperative approach?
It's a great question. I mean, it's been my bias over the years to do the surgery up front and to do the systemic. I try and limit it just to epithelioid patients. And, my reasoning has been that some patients will progress through systemic therapy and go from operable to inoperable. I've had a few patients, especially back when it was cisplatin almost exclusively, who, incurred some sort of renal damage. They went from safe candidate to unsafe candidate. And until there was some sort of, and I'm happy to participate in any trial. I think maybe with the immunotherapies, doing it up front might be better. I think, we're doing some trials with that. I was involved in one out of Hopkins, but, we don't know. But that up to the as a candidate, all things being equal, I would do the systemic therapy out back.
Thank you.
Joe, just following up actually on surgery. I mean, we understand a lot more about molecular features and genetic features and prognosis. And I just wonder whether you feel that biology may play into outcomes in surgery in such a way that we need to think about looking at biology and stratifying on that basis. Is that something that you're already doing, or maybe on the horizon?
I mean, 100%. I mean, it's all about patient selection. And maybe, I mean, I got equipoise about this. Maybe surgery doesn't help anyone, but I mean, I showed a bar graph where you have, you know, and this is a limited, you know, there's 20, 30 series with outcomes that exceed the chemo arm of Mars 2, right? So, you know, people are getting, you know, 3, 4, 5 years of median overall survival for a similar population. It seems like surgery is doing something, but I mean, I've had an epithelioid. Melissa and I recently took care of a patient, epithelioid. I mean, he ticked off all the boxes. You know, I think I measure the tumor volume at the end of the case. I take the actual cancer and submerge it in saline and see how much it displaces. I mean, this guy, and for us, you know, in our series, if they had less than a 500 milliliter tumor volume, depending on nodal status, I mean, the median overall survival sort of been in the 5 to 7 year group. This guy had like 150 cc pure epithelioid, and he exploded like 2 months after surgery. That's something that you would be looking for. Yeah, I mean, that patient shouldn't be having surgery. You know, it's about patient selection. We don't have you you know, we don't have like a common denominator of a staging system like you do with lung cancer. You know, you have lung cancer, you can say, you know, we're going to do a lobectomy, so that's a standard operation. We can test all these different adjuvants, neoadjuvant therapies to combine with it. Understand this, we don't have that with meso, so it's really going to come down to, you know, patient selection and then ultimately figuring out if surgery is beneficial or not. But at the end of the day, you know, taking out a cancer that's a half liter or a liter, it seems like a good start. You know, it's a good adjunct to the fire engine. You know, if you it's a more powerful pump at least to maybe get started to put the fire out. I don't know. But yeah, I think the molecular stuff should be part of the staging system and should be part of the selection criteria for who, if anyone, benefits from surgery.
Thank you very much indeed. We have a question here actually from Richard Wesley. I can't see the question, Sean. Don't know if you...
Yeah, so there's a couple of questions. One is from Richard Wesley. I think he has gone through your slides in the surgical talk, and he wants to know that the slides demonstrate a substantially longer overall survival for the surgical patients when compared with Mars. What are the potential explanations for this?
Patient selection?
Yeah.
I mean, I want to get to look. I think Mars was an incredible effort, and given what was done was as you know was incredibly well done. I was actually on the scientific monitoring board for that, and I think that you know it was as rigorous as could be. But I mean, there are just some things that you look at, like you know the mortality was 9%, whereas you know most is you know 0 to 3%. I mean, it's just hard to compare them. So and you know everyone's doing something different. So one explanation is that the way you know they didn't have PET scans, for instance, in Mars 2. So, you know, you're maybe selecting patients who, you know, definitely should not, that we would have excluded. I mean, I think a big part of it is probably patient selection. But the other thing is, you know, people across the world are sort of doing what they've kind of honed over the years to seems to be, you know, more effective. And the surgery, it's just such a hard thing to get across. But, you know, even though I may try and accomplish the same thing with every operation, a patient who has a 200 cc cancer is going to end up getting a different operation than a patient's got a 2000 milliliter cancer. You know, one may lose their entire diaphragm and one may not. So you know, I think so for instance in Mars, they took the diaphragm out of pretty much every patient. It looks like that probably makes a difference with your ability to recover from the operation, quality of life, those sorts of things. We don't know the answers to these, but I think probably patient selection is the biggest the biggest difference. But, are these other treatments a little better or a little different? I don't know.
Thank you. There's another question here. Could we ever get to the point where we give people at very high familial risk and who have had environmental exposure preventative drugs, especially if we have early biomarker?
So one for Marjorie.
Yeah, she's gone, I think. I mean...
Oh, no, she's back.
Oh, great.
Here, I got zoomed out and in. So I missed the question, though, because I got...
Sorry, Marjorie. So essentially the question was, could we ever get to the point where we give people at very high familial risk and to have had environmental exposure preventative drugs, especially if we have early biomarkers?
Yes, I mean, I absolutely see that on the horizon, and that's what I think, ultimately will have the most impactful, shift on what's transpiring. I think, here to date, whatever cancer we're thinking about, chemo prevention or, medicine intervention used to prevent the emergence of disease hasn't been successful. But at least, in oncology, increasingly, that's where we're focusing in so many diseases. And it's really a missed opportunity, I think, for meso, because we know who the very high-risk people are. It's not a population-based effort. It's a subset. I mean, everyone's at risk because we probably all have some asbestos exposure, right? But we know who the increased risk group is within that.
I have one thing. So, I mean, all of us have had the two sisters who show up in the office. They wash dad's clothes. He was a fireman or he worked in the garage. One of them has meso and the other doesn't. And the one sister says, what do I do? Right now we just follow them with CAT scans. So we actually, Joe Tessa and I have an NIH, prevention grant looking at sulforaphane, which is basically, cruciferous vegetables. And I don't want to spill the beans too much, but in an asbestos-induced meso mouse model, it actually looks like it may have potential. So you got a natural. That's the ideal thing, a natural supplement that has no real toxicity we know of. So there may be some things that you could do for the patient who's been exposed that are low risk. And I agree 100% with Marjorie. Trying to intercept this before it becomes an unfixable problem is a smart strategy we should be pursuing.
Well, thank you very much indeed. Thanks for the questions. I think in the interest of time, as we're a little bit over, I'll say thank you again and just hand over to Sean for some closing words.
Thank you, everyone, and thank you to all our excellent speakers. It's been a brilliant 4 hours of this webinar. I think as we bring this forum to close, I want to thank everyone who's made today possible. I think there's been some brilliant talks, and we've gone on from understanding the fundamentals of pleural mesothelioma, peritoneal mesothelioma, through to the latest developments in precision medicine, radiotherapy, and what's lying ahead for us in the future. And I think this has all been guided by some outstanding speakers from across the world. Thank you to all the speakers for so generously sharing your time and expertise, and to the patients and carers with us today. Thank you for your courage and engagement. I hope you take away with you not only new knowledge, but a renewed sense that progress in mesothelioma is real and ongoing, and is driven by a community that's very keen on getting to eliminate this disease. So we look forward to continuing this conversation in the future, and I welcome you back at any of our future events. Thank you all once again.
Thank you very much, everybody.
Thank you very much.
Bye-bye.
Bye-bye.